Shall I start?
1 minute, ma'am. It's just going live. Okay, it is live now. I'm sharing my screen.
Good evening, everyone. A very warm welcome to a series of E-Classic for Clinicians, PPS Skill and Drill. A very warm welcome to the societies of Gurgaon, Ambala, Rohtak, Hisar, Yamunanagar, and Palwal. This series of E-Classic for Clinicians, the aim being to spread awareness about the different aspects of PPH, its identification, prevention, and management to each and every society from east to west and north to south. The person behind all this hard work is a key organizer, Dr. Sadhna Gupta ma'am, our Foxy presidential candidate 2024. As obstetricians, we all must have felt the wrath of PPH now and then. And very often it comes when we are not prepared, we have less staff, or probably at night when we are not very active, and then we are all in a soup. So earlier we had such few interventions, like we had oxytocin, and if it failed, probably we did uterine massage and we landed up in obstetric hysterectomies. But now we have so many interventions and such good drugs, carbetocin being a boon, it has decreased the incidence of PPH to a great extent. Then we have so many other maneuvers. We have tranexamic acid. We have the bimanual uterine compression, the uterine balloon tamponade. We have the compression sutures, be it the Heyman suture or Whelan suture or the Cho sutures. Then we have the devascularization procedures, and of course, internal iliac artery ligation. And to add cherry in the cake, now we have the SR cannula, and the person behind this invention, Dr. Samarth Ram, is with us, and he will be showing the video regarding this. So before beginning our webinar, let us all join hands and think of Lord Ganesha, Vignaharta, so that our webinar moves smoothly. And let us all join together also for the lighting of the lamp. Pranjal? Kindly.
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा.
लंबा हो जाएगा.
Now it is time to invite our key organizer, Dr. Sadhna Gupta, a very kind and humble lady with great academic skills and leadership qualities. We know Madam is co-chair Suffolk NCT Committee and Foxy representative to Suffolk. She's Vice President Foxy 2016. She has held almost every important position in different associations and societies. And now we had to see her on the highest post of Foxy. She is the Foxy Presidential Candidate 23. She is the recipient of several awards, be it the Korean Award, the AICOG Research Paper Award. She is author of several books, be it cesarean delivery, vaginal delivery, and so many other things. She is key organizer of so many national and international conferences, CMEs, and workshops. Madam is been honored at the national and international forum for her exemplary work. Achiever Award 2023, Pride of Foxy Award 2019, and Foxy Star Award 2016. And above all, she's a great human being. She aims to bring a change in Foxy, so we all wish to see the change. A very warm welcome to you, ma'am. And it is my request to you to invite and introduce our chief guest and guest of honor for today.
Thank you, Babita. A warm welcome to yet another series of E-Classic for Clinicians. And I owe a big thanks to office bearers of Gurgaon, Ambala, Hisar, Rohtak, Yamunanagar, and Palwal societies. Dr. Ritu Jain, Dr. Anjali Verma from Gurgaon, Dr. Poonam Lumba, Dr. Sugandha Chopra from Ambala, Dr. Ranju, Dr. Meenakshi from Hisar, Dr. Pushpa Daya, Dr. Krishna Daya from Rohtak, Dr. Jiten Gadda, Dr. Nishu Gupta from Yamunanagar, and Dr. Kanika Chechi and Dr. Teena Gupta from Palwal. So we know that coming together is a beginning, and it is on your great cooperation, contribution, and giving the time that we are together in our mission of saving mothers everywhere. We have an amalgamation of big societies where we have a prime teaching institution like Rohtak, and it is my fortune to just visit to be with the esteemed faculties and teachers of Rohtak to Gurgaon, and we have the small societies because we all believe in learning, sharing, spreading knowledge, and hand-holding of all obstetricians and gynecologists whenever we need each other. So a warm gratitude for always being together. And this name E-Classic for Clinician is this, that we have what is the basic, very, very strong classical teaching, which is supported by all latest evidences, latest recommendation, and innovations from our own country, and the expertise and experience from our own country. So this is the comprehensive vision which as a professional body we can achieve together. With this, it is a great pleasure to have a very, very dear friends, Dr. Ragini Agrawal and Dr. Mitra Saxena with us. We had a long association with Dr. Ragini, and she has taught me many, many things in life. And Dr. Ragini has been like a very, very a key person in joining and in framing many societies. So she has been the President Indian Society of Aesthetic and Regenerative Gynecology, President Indian Academy of Cosmetic, Vice President 2020, and the President-elect of NIGF, Founder President Association of OB-GYN of Haryana, National Convener Indian Menopause Society, and has been the patron Gurgaon Menopause Society. Above all, she is a very vocal voice for the doctors' unity, for the safety, for the rights of doctor, and we owe a lot, and we look forward to see Dr. Ragini's like a presence, a voice, because we really need her more than ever in current challenges. So welcome Ragini ji, and we wish you to hear a few words from you for Pulse of Wisdom.
Thank you so much, Sadhna ji. Very good evening to all of you who has joined, and welcome to my Haryana. The topic which you have chosen is really a necessary for the all obstetrician, because PPH is almost predictable and preventable, but sometimes it is unpredictable also. So we should be very much prepared how to tackle the PPH. And this is one problem when it occurs. If you are not prepared, you are going to lose a life, which you can prevent if you are prepared. So I hope after today's webinar, most of us is really going to benefit and understand the basics of it. And today we have Dr. Samantaram with us, and his cannula, we all know it is very, very famous, although I haven't used ever, but I have heard many times. And this is one thing which should be in the labor room of each and every doctor. And thank you again, and wishing you very for your future endeavor, who is between the 1st August to 10th August. I think with the North India unity, we are going to see something different. Thank you so much. Over to you.
Thank you, Ragini ji. And yes, this is the something behind what we can say the non-technical issue in PPH, as well as bringing the change, that is the unity among like-minded person and unity among us. So thank you very much. We know, Ragini ji, you are very busy at this moment of time, and thank you for sparing your time. And it is a sheer pleasure to have Dr. Mitra Saxena as a guest of honor. And we actually congratulate to be becoming grandfather. So our all best wishes and the congratulations to whole family. Mitra, Dr. Mitra have been
Sadhna, excuse me. Please don't introduce me to my family. Right now, what is most important that all the people who have joined, they are my family, just like Ragini said. You are our guest and you have designed this beautiful program. So I am sorry, I apologize that I'm cutting you short, because I really want that all the people, the faculty and the delegates, they, whatever time they are going to spend, it will be, like revising. So I want to welcome you, Dr. Babita, all faculty from Lucknow. Of course, my dearest friend Ragini. We all know one thing, that the topic for today is what is going to, attract everyone. Because मेरा अपना जो मानना है वो ये है कि जैसे बार बार सुंदरकांड का पाठ होता है, बार बार हनुमान चालीसा पढ़ी जाती है, तो उसी तरीके से पीपीएच ऐसी पोथी है, जितनी बार पढ़ोगे उतनी बार रट जाएगा. और when you are in a medical college or a corporate hospital, you have plenty of heads together. But when you are alone, then all these plenty, seminars come into your mind. अरे उसने वो point कहा था, उसने ये point बताया था. So because the decision making in PPH, especially when it is when to do the second line of medical management, when to do the surgical management, being alone, actually, these are the times कि जितनी बार अपन ये करते हैं, ये एक service है to all the Foxians. So at the outset, first I want to thank you, Sadhna, for designing a very important session. I know Babita has been a part of the team. She has presented beautiful webinars. I am actually being, by God's grace, the chairperson of Practical Obstetrics Committee. मुझे तो ऐसे लगता है कि शायद ऊपर वाला चाहता था कि मेरे से complications कम हो, तो मैं कुछ पढ़ लिख जाऊं. डॉक्टर समर्था राव, वेलकम फर्स्ट हैंड. आप जब अपना वीडियोस दिखाओगे, when you will share it with the audience, then all of us who know the theory part will be able to look at the videos and cross question you. And then the topic, of course, what Sadhana is going to take is the starting point of PPH. Then go over to Dr. Sadhana Samartha and my dear friend Shashi, who's going to speak on the surgical management of PPH. And then, everybody knows that this has really shaped our own thinking, because we are in private sector, we are single-handed. So obstetric skills and drills and being prepared for the emergency and all these things in our mind, this is imperative. Then the panel discussion. I am really so happy that on both sides of the firing line, those who are going to question and those who are going to answer, they are all extremely experienced people. So friends, all the people from Haryana, all those who have logged in, actually I am very grateful to Corona कि उसने हम लोगों को ये digital पढ़ाई लिखाई का वो दिखाया है. While we were doing our post graduation, we were writing answers as a theory. But now we are actually dealing with practical exam every time we are delivering a patient. So anticipation. I personally want to share this, Dr. Sadhana, that in my cases of anemia and in cases of prolonged labor, all those whom I have put Syntocin on, I have started using carbetocin strat for active management. So little changes which we do in our own practice and we find the results are so good. I wish everybody very safe, happy obstetrics. Please don't leave obstetrics. It is our bread and butter. It has been obvious during Corona times कि सबकी दुकानें बंद हो गई थी, पर obstetrician के काम चलते रहे थे. So I wish that Dr. Sadhana, you achieve success because you are worthy. And everybody who is here should take the benefit of the spirit of the seminar today evening. So over to the faculty. Babita, please go ahead. Ayushi, all of you, I wish you a very warm welcome. And Haryana ke jitne log yahan join in kiye na sadhana, they are all my very, very good friends from Palwal, from Yamunanagar, from Ambala, from Hisar, from Gurgaon, everybody. So namaste. And thank you for making
thank
me
you,
feel
Veera, and always thank you for always being in life. And we have been very sharing a lot of things together, ups and lows, and that is the time we really need friend. And हरियाणा में आज ये कहने हरियाणा में कुरुक्षेत्र था और जहाँ महाभारत हुआ था और that was the fight for the values. और मैं अपील करती हूँ कि हरियाणा एक बार फिर इस महाभारत युद्ध में वैल्यूज के संग रहेगा और सारा हम लोग किसी बहुत अच्छे काम के लिए आगे बढ़ेंगे साथ साथ. So thank you, Ragini ji, thank you, dear Mitra, and Babita, you go ahead because both of them, our guests, were very, very particular about time. So
and I will be there. I will be listening to everything.
मैं भी सुन रही हूँ.
Thank you so much, ma'am, for being with us and sharing your wise inputs. Again, before starting the session, I would request the faculties to kindly share the flyer and link in your society. You want more audience today. Usually we have a good audience every day. So let's quickly...
कोरोना का फैकल्टी रहता है प्लेटफॉर्म.
नहीं डेलीगेट लिंक भी था मैम. डेलीगेट लिंक भी शेयर किया है. अभी दोबारा शेयर किया.
हाँ, इसमें नहीं आता है एक्चुअली. कोरोना का जो डेलीगेट प्लेटफॉर्म है ना, वो डिफरेंट रहता है. हाँ, शील वालों का से.
अच्छा, तभी मैं बहुत परेशान थे कि मेरे को कोई दिख नहीं रहा है.
Sadhana ji, don't worry. We are continuously spreading the news,
so
and we are there.
Thank you. Thank you.
So let us all quickly move towards our first scientific session, resuscitation and medical management in PPH. The speaker is none other than Dr. Sadhana Gupta ma'am. And I would like to invite our esteemed chairpersons for this session, Dr. Pushpa Dahiya ma'am. She is president of Rohtak Obs and Gynae Society. She has a 33 years of teaching experience and is professor and HOD of Obs and Gynae PGIMS Rohtak. She is master trainer of emergency obstetric care, president of Rohtak Obs and Gynae Society, faculty at various national and international conferences, external examiner for PG exams in various national and international universities, and ma'am has more than 100 publications in national and international journals. A very warm welcome to you, ma'am. Then
Dr. Ritu Joshi is not the president of Gurgaon Society, Babita. Dr. Ritu Joshi has been the past vice president. So, yes, go ahead.
So, ma'am is chairperson.
CV is white. CV is fine and photograph is fine. Yes.
Ma'am is chairperson, Family Welfare Committee, 2009 to 2012. She was vice president Foxy in 2014. Madam is senior consultant in Fortis Escorts and Surya Hospital, Jaipur, Rajasthan. A very warm welcome to you, ma'am. I would hand over the session to our chairpersons to invite and introduce our speaker.
Thank you so much, Dr. Babita. First of all, I would like to thank Dr. Sadhana. She has again given me an opportunity to see you all virtually. And I don't think so Dr. Sadhana Gupta needs any introduction. Today on this platform, all we can say all over India, everyone knows about Dr. Sadhana Gupta. Her academic excellence, I think Dr. Babita has already said, in addition to that, she is a great academician, researcher, and she is having a great organizational capabilities. I think not even the national level, even at the international level, she has put a lot of impact and she's having experience. She has already done so many Foxy. She has represented Foxy at WHO, at in international level in Sri Lanka, Delhi, Colombo, and various places. She has been a very good speaker. So I think we all know about her. So we should not waste our time because everyone knows about the Dr. Sadhana. Now we should learn from her how we can manage the PPH, how we can prevent the deaths of the young females when they are there in labor. So this is a very important topic. So I welcome Dr. Sadhana Gupta, and I think now we can start the topic without wasting our further time.
Thank you, Dr. Pushpa, for your kind introduction and setting the stage for all the context. And I will be dealing what we do, two things actually, what we do in our day-to-day practice in antenatal care, the second thing in our system, and what we should do, the protocol when patient is not having PPH, and the fourth thing when the patient is having PPH. So it is all about the like decision making, cause analysis, and making your team of friends and your like a confidence building team. So thank you always for staying together, first of all, because when we really work selflessly and emphatically for professional bodies organization, what we achieve, the company of the great friends, and these are the memories of just like a few weeks ago when we were together, and we come to know actually that how our members, our teachers, our professors are creating future generation of OB-GYN, dedicating their services. And as a presidential candidate, this is my one of the commitment that we will be all inclusive, all involving, so that our expertise, experience, your saying your issues and concerns are taking to the wider platform. And as a country, we should lead the world because we are catering to the largest and heterogeneous population of the world. So I bring greetings from land of Buddha, who says we can never obtain peace in the outer world until we make peace with ourselves. And it is so very true when we are dealing with postpartum hemorrhage. So postpartum hemorrhage, it remains relevant because what Mitra says, we have to, हमको बार-बार उसको rehearse करना होता है, और ये conscious breaking such हमको बार-बार चुभना चाहिए that PPH is contributing to around 30 to even 60% of maternal death, especially in our region, and we are losing around 150,000 mothers annually worldwide. As a clinician, when we are really taking OB-GYN as a practice and doing any sort of obstetrical practice, we are bound to get PPH in 2 to 10% of all deliveries, and out of which 1 by 1,000 can be massive and life-threatening. Very rapidly, organ dysfunction, irreversible shock, death can occur within a very short span, and it leaves a long-term scar on the mother's health. It is a maybe hysterectomy, sometimes admission to ICU, problems of massive blood transfusion, nutritional deficiency, social abandonment because the patient is having secondary infertile, and the PPH related mortality is what we know. We remember with a lot of pain that it remains a lifetime scar for obstetrician and our team. So it is India, when we are having a third largest economy of the world, actually we are losing a lot of mothers due to postpartum hemorrhage. The PPH is something adversity. It is something a challenge which is putting to you. Sometimes you are prepared, sometimes you are not. And every challenge is text your personality, your what you have done. What I said that आपने क्या आप रोज अपने हम डे टू डे अपना जब लाइफ करते हैं, like we are going through the hospital, we are going through labor, how much input we have given, because we can have postpartum hemorrhage in around 10% of all, but multiple causes can occur, but we have to be ready, and it tests our leadership, our composure, our knowledge, our expertise, right from the mindful thinking of the cause analysis to the expertise and the availability of instruments. So it tests actually within a short span of 1 hour, it tests your everything in the system, and more we can able to save the postpartum hemorrhage related criticality and morbidity, we can say we are very, very strong. In India, we have all age-old problem. We have extreme riches and extreme poverty. Still, we have the less availability of care, quality of care in rural system. And we have every third woman is anemic, that making the PPH management more and more difficult. And we have all the new things, what is in the developed world, that is the obesity, comorbidities, pregnancy with IVF, pregnancy with myoma, pregnancy on different drugs. And the many textbook does not mention all these things in their routine teaching. And as we are having a lot of these patients, we have to be ready with our own experience and own management plans for these situations. So what we want to achieve through this webinar, that we have a good protocol in labor room, in antenatal clinics, and we have the very clear mind that what is the cause of PPH in this patient, so that we take the right decision for all the management what we learn. If we don't manage the postpartum hemorrhage, it is a implication can be very, very huge for mother, for neonate, family, obstetrician, potential medical, legal, media, and social issue, and we cannot escape beyond it. Today is the time when we have a very strong political will for saving mothers. We have a good ambulance, good roads, good community health worker. Yet this is very important that when the patient with PPH comes to us, we are having the very, very strong blue code, so everyone is alert and we don't waste any time in managing the patient of PPH very, very aggressively. Prevention is the way of present and the future medicine. Is the way of present and the future medicine. So our actually prevention start in the piece when we are in the antenatal clinics or we are having in OPD. Take very good history of all risk factor. What is the location of placenta, multi-pregnancy, any drug intake, any preeclampsia, any pre-existing bleeding disorder. And important thing is the knowledge should be turned into action. So when you have identified these risk factors, flash on antenatal card, counsel family for PPH. When you go to a delivery to any place, like ask them to show this through the labor room staff and sensitize every labor room staff that they take all the necessary measures, because this patient can be high risk for the postpartum hemorrhage. Active management of third stage of labor is the thing where I have really spent a very, very closely for a very simple thing in Foxy for 20 years. And I feel very happy that when we started helping with the Survive program and Path Oxytocin initiative in 2013, that is around 10 years ago, oxytocin was not kept in the fridge. We have multiple ways of active management of third stage of labor. And now we have come a long way. When every obstetrician, most of the 90 to 95% people are aware that oxytocin to be kept into the refrigerator, and every woman who is delivering, be it an institution, be it community, has a right to have the active management of third stage of labor, because it reduce PPH, decrease need of blood transfusion, decrease need of anemia, and decrease need for additional uterotonic medication. Now with the bar that the delayed clamping of the cord, if the baby is fine, it has the additional advantage for baby also. So the strongest arm of active management of third stage of labor is a oxytocin 10 unit. You can give intramuscular, you can give in the intravenous infusion. The beauty of oxytocin is this, that there is no contraindication. Every person can give it without thinking a bit about the drug. And if you give intramuscular, it is a sustained uterine contraction and no effect on vital. Misoprostol we are using a lot. Just one message I wish to communicate, that misoprostol is a second choice for the postpartum hemorrhage prevention, active management of third stage of labor. The beauty of this drug is that it is does not require refrigeration. It is very cheap. You can give it oral sublingually. But if you are giving rectally, make sure that it is not going to work for the MTSL because it takes around 40 to 60 minutes by rectal route. So important thing is, but it is a second choice and the oxytocin remain the first choice. All professional bodies strongly recommends the active management of third stage of labor, and we have waited a long for this carbetocin, which is now available in room stable as well as the like a thermal labile. We can use anyone. Important thing is that carbetocin has a very strong affinity to oxytocin receptor, and secondly, it is a long-lasting oxytocin. So it makes our job very, very easy, especially in the elective cesarean, because the patient does not have any endogenous oxytocin. Carbetocin works wonder, and it also functions to thicken the blood, which further prevent the postpartum hemorrhage. After champion trial in which India contributed in a big way and in a very, very significant way, it is found to be effective as oxytocin or superior for the active management of third stage of labor, both in cesarean as the vaginal delivery. And what like Mitra was saying, I am also using carbetocin as a first choice of drug, be it a cesarean and be it a vaginal delivery. It is just a matter of around 300 rupees extra, which is actually equivalent to the IV infusion and the other thing. And our women owe it. It is not a very costly drug, and I appeal that everyone should use the carbetocin as active management of third stage of labor. When we are having a lot of high risk case, every third woman is anemic, we are worried about the oxytocin continued infusion. We call crystalloid oxytocin, and carbetocin eliminates the requirement for infusion after initial dose. So this is very important because we are having around 10 to 15% hypertensive disorder, pregnancy, anemia, valvular heart disease, where the carbetocin can be very, very good choice. Above all, the non-technical matter plays an important role in PPH prevention to management, because we must have a system which is active and live. We must have all uterotonic agent available with cold chain provision, all the drugs, all our armamentarium, and above all, our skilled birth attendant, our nurses, our junior resident, our MBBS, whatever doctors we are having, they must be knowing that what to do for prevention and how to diagnose and how to treat the initial step in the postpartum hemorrhage. So this is the important thing, that the administration of uterotonic agent within 1 minute of birth of baby. And for this, you have to train to your paramedical when the patient is just going to deliver, preload the carbetocin or oxytocin so that no time is lost. Finally, the PPH remains unpredictable, and more you sweat in peace, less you bled involved. This is the way of life, and we have to, what we do in our first hour, we do the correction of hypovolemia, and we see what is the cause of bleeding, and we have a control of bleeding. So that is the golden hour where we have the maximum chance of saving the mothers from criticality as well as the mortality. So the one very important message which I wish to give, that never and never shift the patient from labor room or to the like a normal OT, or right from the cesarean OT to straight away to the postnatal ward. The all patients who have delivered in by any mode, they must have the policy in our hospital, be it a small nursing home, be it a big hospital, that they are being observed for 2 hours for bleeding, PV, tone and height of uterus, vitals, what is the level of alertness and oxygen saturation. If you make this policy, you are very sure that it is going to pay off, because you will not handling that severe PPH and the irreversible shock. So primary PPH, secondary PPH, we know, but as a clinician, when we are called, what we do, first of all, the quick 360-degree view of whole situation. She is bleeding. It is not that we do it 1, 2, 3, 4, 5, or you start using all the things. We have to have a very smart cause analysis, a quick review, what can be the cause, tone, tissue, trauma, thrombin, a quick review of antenatal clamp, quick review of the ultrasound, what happened into the baby. It was induced, it was referred, it was prolonged labor, it was a predisposing factor for the DIC or the coagulopathy like IUFD or the HELP syndrome. So the cause analysis, and you can have more than one cause. So this is very important, and placenta, if it is retained, always you have to see that the placenta is complete or not. So the patient is not going to normal ward, and the placenta also going to be there for next 1 to 2 hours, so that you can always be reassured that placenta was complete or not. So this is the very, very important part. You can have multiple cause, especially in today's time when the patient is having she is having preeclampsia, we are giving Maxel, we are giving nifedipine. The patient of the prom are carrying on till she becomes a little bit more gestational maturity, and you can have all complete combination of the cause for the PPS, that is infection, atony, use of tocolytic. Why we have failed in diagnosis of PPH for such a evident thing that patient is bleeding? Because the pregnant patient is having the hypervolemia. Nature has been generous to the mother because they give the high hypervolemia so they can withstand that normal blood loss which happens into the pregnancy. So there is no immediate change into the pulse and blood pressure, but the visible estimation of the blood loss, that should be learned to everybody, and with the hundreds of workshop, physical and the personal, what we have conducted. And when we are putting these swabs with soaked in the red ink, and we ask the people that what do you think, how much is the blood loss, it has been improved. The important thing is that you give the correct, like a very, very precise things to your labor room staff. If she has soaked 5 normal size pad, if there is a 1 soaked mixed sanitary napkin, continuous trickle of blood, or you have Chhattisgarh or the Devdas bag for the quantification, or the patient is having any alteration which seems a little bit disturbing, she is nausea, she has vomiting, she is cold and confused, that is the time to call senior person. And when you call, you are being called, on the way you have to call all your friends. And who are the friends? This is the one thing is very, very important in life. Our anesthetist, who is always with us, morally boosting 24/7, senior nurses, one good colleague, all smart as ward boys and guys, alarming to the theater staff that don't put the another case, we might need operation theater, and the blood bank person. So these are the things which are smart, as a smart leader and as a able leader, we get along with our team. And the third thing after the diagnosis is the quantification of the postpartum hemorrhage, because more blood loss, more aggressive you have to be. Pulse BP, it is not a very hard science, it is not a rocket science, it is just a review of the pulse, blood pressure, tissue perfusion indicator, amount of urine output, and the capillary refill, which can give you within seconds idea that how much amount the patient has lost. And shock index is something very, very simple, maternal heart rate by systolic blood pressure. But important thing is that our labor room must have the multi-parameter cardiac monitor. So our nursing staff is confident, yes, this is a high blood pressure, high maternal rate and the low blood pressure. If you have shock index less than 1, you have a breathing space, but more than 1, you have to be very, very aggressive. Classical teaching, rule of 30, we have to retain it, we have to imbibe it, we have to inculcate it. And once you have diagnosed PPH, it is quantification, that our system should be ready. And all the things which are very, very small things, drugs, oxygen cylinder, along with the key, airway, emergency trays for PPH, chart for PPH management, and all numbers what we of the friends. So that is the basic EMOC what we have is going, and we have to, if it is a mild PPH, you can go for the 2 IV line, give crystalloid, give antibiotic, record event, and ongoing hemorrhage, because many, many times it happens, you think that it is a mild PPH, patient is okay, and within 30 minutes you are again called that the blood pressure is actually dropping, and you are really, patient is losing the moderate to severe PPH. So the quantification and the observation of the patient, even with the mild PPH, is very, very important. And when there is a less bleeding outside, but the more signs of shock, always look for the internal bleeding and the internal cause for the postpartum hemorrhage, because these patients really create a lot of issue with this. Many times they need the surgical management, and these patients have to have an emergency ultrasound also for having what is the cause of this concealed bleeding. So airway, breathing, circulation, give oxygen at 10 to liter per minute, regardless of oxygen saturation, and 2 IV cannula, that is gray and green. This is very important. No pink cannula is to be used in these situations. Keep patient flat, keep patient warm. And the crystalloid, our way, which is going to save us, give us the time that the patient does not go for the irreversible shock. Give oxytocin, catheterize bladder, because you want to see blood in urine, amount of urine, and excess need of the blood transfusion. Manual aortic compression is the thing which comes at this moment, because a situation like placenta accreta spectrum, we suddenly have a torrential bleeding in a very short time, and on this situation, that shifting the uterus and putting the like a full straight hand with the hand out, this thumb outside, can give you a little bit breathing space. So resuscitation, investigation, monitor, communicate, and record keeping, whatever the situation is, you have to be in confidence with the patient relative, so that we don't waste time in argumented decision making. When you are putting the second cannula or the first cannula, even any IV cannula, you take the blood sample at the same time. For this, you must have 2 to 3 plain vial, 2 to 3 citrated vial, and 2 to 3 EDTA vial, because sometimes they get broken also. For blood cross-matching, for coagulation profile, for hemogram, and the organ function test. And here is the PPH care bundle, which we wish to percolate all sepsis, PPH, preterm care bundle to pan-India, so that we can really make a change in improving the maternal health statistics. So the first response PPH bundle is the uterotonic drug, crystalloid, tranexamic acid, and uterine massage. I will stick over it, and all these things which have been done. And which fluid, that is very important, that is crystalloid, either ringer lactate or normal saline. Why? Because they rapidly equilibrate into the extravascular space and does not retain intravascular, so less likely to have pulmonary edema. They have a good tissue perfusion, and if you assess that it is a 1 liter blood loss, you give around 2.5 to 3 liter of the crystalloid. So ringer lactate and normal saline, many times, sometimes still the people say start with hemaxil. So hemaxil or the colloid is not to be given initially. You have given around 2 liter of crystalloid, then the blood patient having ongoing chance of bleeding and the blood component not available in between space, there is a little role of the colloid. Always ask right question. Placenta delivered, it is complete. Bleeding start after delivery of baby, before delivery. Placenta not delivered, start mobilizing team for MRP. Even when you are thinking it might deliver spontaneously within 30 minutes, because sometimes patient pass into unexplained shock, and we are really no way, because we have no system, patient not shifted to OT and anesthetist is not there. Placenta not complete, explore genital tract. But if there is a suspicion of past disorder, previous section, adherent placenta, multiple like DNC, then never try to do the exploration. Have to have the retained technique for good fundal massage, evacuation of blood clot, because that makes our finding the blood clots removal itself cause the reduction in postpartum hemorrhage of uterus, especially in obese women, because mild degree of inversion is also the cause of PPH. We have wonderful drug now. We are today very fortunate when we are having, beside oxytocin, methergine, carbetocin, misoprostol, prostaglandin, F2 alpha. Important thing is they must be available. Second thing, we have to optimize their use, good cold storage, exclude the contraindication, and use in the good dose. It is not so you give only 1 methyl ergometrin not working, let us take 2 OT. It is not so you can give 4 ampule of methyl ergometrin at interval of 15 minutes, 8 ampule of PGF2 alpha, that is total 2 milligram in the at the interval of 15 minutes. However, if you I have given around 3 unit of the 3 ampule of prostrodin. That is the time you have to think that this patient might need the second label measure. If one drug is not effective, second drug will be effective, especially when you have used oxytocin as an induction agent. Oxytocin or carbetocin might not be that effective, and you have to resort to misoprostol or PGF2 alpha. So understanding every drug, excluding contraindication of every drug, availability of drug, and optimizing the dosage of drug. That is the key, because we are very, very fortunate to have all the drugs, but optimizing all these drugs is very, very important. Tranexamic acid has come in a big way after women trial. And first of all, I was fortunate when the initial studies of tranexamic acid were presented in FIGO. And now it is considered that you should give in prophylactically in all high-risk cases of PPH. And when you diagnose PPH, it should be given within 30 minutes, repeat it after 1 hour, but no use after 3 hours. After 3 hours, it can be a little bit harmful as well. A word of caution that the tranexamic acid ampule is like the same as the bupivacaine, and there has been accident that it has been inadvertently injected as a regional anesthesia, and patient had the mortality or the severe criticality. So keep a magnifying glass in operation theater, because there are many drugs which are actually looking ampule, and we have a busy or sometime the chaos happens. The humans can error, and we must be very, very careful about it. Consider blood transfusion if moderate to severe PPH. Hemoglobin is less than 7 grams, and for this you can give a quick HemoQ test for the immediate assessment, what space you have, and ongoing bleeding, ongoing coagulation profile. Whenever there is a precedent obstetrical situation like HELP, IUFD, the placental abruptio, think of coagulopathy. Always retain all these art of the bedside test, because whatever, even in institution, it takes around 30 minutes, and after 30 minutes to get the thing, it might be the time to repeat. So these are the simple tests. A simple test tube, you take the blood and you just see what time it takes to clot formation, and what it is a solid clot, it is a stable clot or not. And it really gives you, and Dr. Nalini Mishra has presented a published paper in the FIGO house that is very, very important, that how these clot retraction tests give you the fairly approximate level of the fibrinogen level. They correspond very well. Massive blood transfusion protocol start after the 3 unit of the PRBC. It is not from the very beginning, but if it is a coagulopathy, then it is 1:1:1, and always it has to be correlated with the coagulation profile, especially the fibrinogen level and the platelet count. After blood transfusion, we want to have certain goals, hemoglobin 8 gram, platelet count, prothrombin time. So we must have a clear goal. We must use the blood component at right time, and we must not abuse also the blood component. So this is important. PPH phase must be there, and like we have propagated right from Dr. Sheila Manish that these PPH trays must be there. We are training in Manyata as well, and the SR cannula and the transvaginal uterine artery clamp. We really propose that these instruments, simple one-time investment in the labor room, these instruments should be available with us. Always record all parameter, event, what you have done, communicate well. It is a real testing time. You must have a very, very composed attitude. Join all Manyata. Our training nursing staff must be good. Cause analysis as per the thing. Always you have to be prepared for all the things what we are happening. This is important when patient to be shifted to OT or not. Here is the thing, we become shaky. It's sometimes to our ego, because the patient is, क्या हुआ आपके पास दिखा रहे थे, operation क्यों होगा? We have to be very clear that when we have to shift to the OT, that is very, very important. What I will say. So I will just go to these slides. So before going to this, that whenever you have the high cervical tear or a cervical tear bleeding, you do the repair with the good setting. Don't repair without anesthesia, without light. What is the transvaginal uterine artery clamp? What do we say? That it really saves the life, because it gives you time, and it gives you also, sometimes it corrects also. So balloon tympanoid, you can have uterine balloon, you can have Bakri balloon, you can make Chhattisgarh balloon. MRP, whenever to be done with the proper art, because the real difficult part, don't hesitate, don't delay the decision. This is very, very important. I Donald golden words that real difficult part about MRP decision to undertake. Coagulopathy, not only because of the obstetrical issues, Apla syndrome, SLE, dengue, malaria, these can call also coagulopathy. We have to be very, very particular about it. Sometimes drug-induced thrombocytopenia, we are using a lot of heparin, and sometimes immune and the thrombotic thrombocytopenia. So this is one thing, when you see that the uterus is flabby, she is pouring blood, you cannot, you are finding to have the cervical, you are not finding the apex, and you are not able to repair. Uterus is indefinite, you feel certain lump, and there is a concealed unexplained shock. This is time you should not delay for the shifting the patient to operation theater. While shifting, you can do all things, NASG, aortic compression, bimanual compression, and develop all the skills for which we are always together. So save life, PPH is something that it should be in our hardcore, even at 3 a.m., even after busy OPD, whatever we are, even after a party, you are not in mood. Our reflex and our mind should be working in a very coordinated manner. We have to be very respectful to our team of friends who always, we really need the multiple hand in dealing these situations. Always keep a sharp eye on potential medical legal issue. Never give the case sheet to anybody, sister. Whenever patient is having PPH, keep this case sheet to you as soon as you are ready with all this citation. Fill it with a very, very good chronological documentation, and keep good communication in worst, even in worst of circumstances. So if you can fill the unforgiving minute with 60-second worth of distance, run. This is the thing. And with this, I again, with gratitude for always being together. Election is just 10 days after this election. I see that every one of you vote for me, and everyone asks at least your 20 friends to vote for me, because together we can really make a change for all inclusion, involvement, and the expansion. Thank you very much for the.
Thanks a lot, Dr. Sadhna. I think she has made everything so clear and crystal clear that I don't think so any further questions will be there. She has told us all the practical points, how to take up whenever the PPH is there, how to prevent it. I think the take-home message is like that from the very early antenatal period itself, we can identify the high-risk women, and when they come in labor, we can manage them very early. And the way the Dr. Sadhna said that nowadays this carbitocin is available, because I think we have all shared with you when you came here that though we don't have an experience, but we have learned so much from you all that this carbitocin is really very effective. So I think we all, especially like those who are practicing outside alone, everyone should have their own PPH kit ready every time in their labor room, which includes all these oxytocics, IV cannula, BT set, IV set, all these crystalloids, some vials for taking the samples, or we can say the tamponade, this SR cannula. I think we have to tell our friends that this PPH kit should be ready with them at every time. Early identification should be there, and we should not like afraid of calling the help. Whosoever is available, we should always call our friends, maybe anesthetist, maybe the other obstetrician, so that at the earliest we can manage the patient very safely and we can save the life of the mother. I think very nice. Thank you so much, Dr. Sadhna. Very nicely you explained. There should not be any further questions.
Thank you.
Thank you so much, ma'am, for your wise inputs and for conducting the session so smoothly. My sincerest thanks to our speaker and chairpersons. Now, quickly moving towards the second session, it is a very interesting video demonstration of SR cannula by none other than Dr. Samarth Ram himself. For this session, I would like to invite our esteemed chairpersons, Dr. Kunika Chechi ma'am, she is president of Palwal Obs and Gynae Society. She is director of Vardhan Nursing Home and IVF Center. She is ex-assistant professor, PGIMS Rohtak, ex-senior MIAMC Delhi. Credit of first IVF baby in Palwal, that is really commendable. Multiple publications in national and international journals, and she is president of Palwal Obs and Gynae Society. A very warm welcome to you, ma'am. We have Dr. Meenakshi Mehta. She is consultant at Nova IVF Hisar and has 8 years of experience in this field. She is life member of IMS, IFS, FOXY. She has won prize in poster presentation in the International Urogyne Conference in Ahmedabad, published 2 international papers and 1 case report in international journal. She is at present secretary of Hisar Obs and Gynae Society. A very warm welcome to you, Dr. Meenakshi. I hand over the session to the chairpersons to invite and introduce our speaker, Dr. Samarth Ram. Dr. Kunika, Dr. Meenakshi, are you there? Dr. Meenakshi Mehta.
Good evening,
Dr.
Doctor. I am here.
Okay. Kindly
Good
flash
evening,
CV of
sir.
Samarth Ram, sir.
Yes,
Randall.
Sir, shall I invite him or he is starting the session?
Yes, just introduce, sir.
Yes.
The CV is there. Just
yes,
introduce
just
him.
brief introduction is enough. Just
Yeah.
that's already known everywhere.
Good evening, everyone. I will like to invite Dr. Samarthram, sir. He has innovated the SR cannula. Sir is working in Kerala and many awards are there in basket of sir. So I just like to invite sir for the video presentation of SR cannula.
Thank you.
The
Thank you
next-
very much. And just
Network issues at your end, I think.
I'll share the screen. I think you are able to see my slides.
Yes, sir.
Yes, sir.
Thank you. Good evening, chairpersons, and good evening, everybody. I'm very much thankful to Dr. Sadhana Gupta ji for giving me this opportunity. Really, she made SR cannula as pan-India. And actually, I was confining most of the times my work was in South India, because Sadhana Gupta only, the cannula is known almost every part of North India now. And I am very much thankful to her. I wish her best of luck, her presidential election. In the days to come, or in the months to come, we would like to concentrate on maternal mortality issues in North Indian states. We are very serious, and I like to bring down MMR in the North India also. The title of the topic I'm presenting, SRPP suction cannula for the management of atony postpartum hemorrhage. Indra, 1 minute. And greetings from Godson country, Kerala. Postpartum hemorrhage is the leading cause of maternal deaths all over the world, amounting to 28%. Around 50% of the mothers die due to atony PPH. When conservative methods like uterine massage, atonic drugs, and balloon tamponade fail, surgical interventions which need laparotomy are needed to stop bleeding. In low resource settings, it is difficult to organize competent manpower, compatible blood, and transport to higher medical centers. Many times, mothers die on roads while being transported to higher medical centers. This is the SRPP suction cannula that I have developed. Measures 23 centimeters long. This is a fundal portion is having larger round holes. Cervical portion is having smaller round holes. This vaginal portion do not have any holes, and this is the nipple of the cannula. It stays outside vagina to be connected to suction machine through tubing. Coming to the mechanism, how it works. This is the atonic flabby uterus bleeding, cannula inserted here. When negative pressure applied, the soft cervical tissues get sucked into the perforations of cervical portion of the cannula and become adherent. Uterus becomes a closed cavity. Further continuation of negative pressure results in constriction, contraction, and firm retraction of uterus on the surface of the cannula, which assists the natural physiological process of contraction and retraction to stop atonic bleeding. Here I am showing the uterus here. Inside the cannula, SR cannula is there and it is working and creating a powerful negative pressure. It is a global constriction of the uterus. You can see rugose, it is not rugose, it is coarse ridges on entire surface of uterus, both upper segment and lower segment. Because of this reason is cannula is very effective to stop lower segment bleeding in case of placenta previa. Once again, I would like to reinforce SR cannula is very effective to stop lower segment bleeding in case of placenta previa. Achieving closed uterine cavity is the basic and fundamental requirement for the functioning of suction tamponade system. 5 different sizes of cannulas are made to match different cervical dilatations and to match different uterocervical lengths. These are the different obstetric bleeding situations have different cervical dilatations and different uterocervical lengths. This is a post-abortal uterus. The uterocervical length is short and cervix admit only one finger. You have to select a thin cannula, thin short cannula for this purpose. Whereas this is a postnatal uterus with 8 to 10 centimeter dilatation, you have to use a larger diameter cannula. If you use a thin cannula in a postpartum uterus where cervical dilatation is 8 to 10 centimeters, and when the cervix cannot grip the cannula firmly, it cannot achieve a closed uterine cavity. For the same reason, the cannula system will not work. These are the cannulas designed for atonic PPH after vaginal delivery. This is lateral view and this is the AP view. Thin cannula is meant for cervix admitting one finger, larger diameter cannula for dilated cervix. These are the cannulas designed for atonic PPH during cesarean section. This is a thin cannula meant for cervix admitting one finger. This is a larger diameter cannula for dilated cervix. I have given a marking here on these cannulas. These are meant to identify which is the cervical portion and which is the fundal portion. When we insert this cannula, you can't see the both the ends. So this marking helps us to identify. And the basic requirement is you have to keep the cervical portion of the cannula in cervical region. This is the cannula designed for bleeding after MTP or vesicular molar extraction. And this is a thin long cannula. And this also used as a suction tube introducer while doing cesarean section. When compared to balloon tamponade, in balloon tamponade, the mechanism is totally opposite. Here, the water-filled balloon dilates the uterine cavity and a distended balloon compresses the bleeding sinusoids to stop bleeding. Whereas in vacuum tamponade system, the natural physiological, it assists the natural physiological process of contraction and retraction to stop atonic bleeding. SR cannula application for atonic PPH during vaginal delivery.
Woman bleeding profusely. Vagina retracted with white blood speck like this. 5 centimeters of anterior cervix is caught with the sponge holding forceps like this. Cannula inserted. Tip of the cannula should be at the level of fundus and should be fed bimanually. Nipple of the cannula should be connected to the suction machine through tubing. Negative pressure should be applied. A negative pressure of 650 millimeters mercury should be applied for 10 to 15 minutes. You can see complete cessation of bleeding within 4 minutes. Retracted well.
SR cannula is so effective, it stops bleeding even within just 1 to 2 minutes. Application of negative pressure. A negative pressure of 650 millimeter mercury should be created and maintained for 10 to 15 minutes, and then the machine should be put off. This procedure should be repeated every hour for 3 hours. After 3 hours, the cannula should be kept in the same position without removal and should watch for bleeding. In case of recurrence of bleeding, a negative pressure should be applied by just switching on the machine. How long to keep the cannula inside the uterus and when to remove the cannula is at the discretion of the obstetrician. For the general guidelines only, I have mentioned like this. Suppose if the woman starts bleeding within half an hour time, the recurrence of bleeding is there, again you have to apply negative pressure. How long to keep the cannula inside the uterus? Usually, the cannula can be removed after 6 to 8 hours. In case of high-risk women, the cannula can be kept inside uterus as long as the bleeding expected, even after 24 hours. Whenever there's a recurrence of bleeding, we can switch on the machine. If you just switch on the machine and create negative pressure, the recurrence of bleeding also stops. SR cannula application for atonic PPH during cesarean section.
Cannula system should be organized while setting the trolley itself. The intended cannula for application should be fixed to one side of the suction tube. Other end of the suction tube should be fixed with a thin long cannula. As this is an elective section, I am dilating the cervix with index finger. I use thin long cannula, which I call it as a number 5 cannula, as a suction tube introducer. Suction tube should be connected to the suction machine. Cannula should be kept in proper position like this. Cut edges should be kept close together. Mop pressure applied. Negative pressure applied. You can see complete cessation of bleeding, contracted and well retracted uterus. You can see practically no bleeding. I am closing the left angle under direct vision. Contracted and retracted uterus. Blood loss less than 100 ml.
I would like to share one information here. For application of negative pressure, you need not close the uterus. You can just keep the cut edges close together and then apply negative pressure. Because of the valvular mechanism, both edges come very much close together and approximate firmly, and it will become a closed uterine cavity, and negative pressure inside will build up, results in contraction and retraction of uterus. You can also apply the surgical pad to seal the wound to prevent leaking of air. Follis catheter tourniquet and SR cannula for lower segment bleeding at cesarean section. This is very much useful in case of placenta previa. In peripheral centers with suboptimal facilities, after delivery of the placenta, you can just apply tourniquet with Follis catheter which results in complete cessation of all bleeding. After application of cannula, we can apply SR cannula.
As Follis catheter is elastic, it permits the application of SR cannula with in situ tourniquet.
Put on the machine.
You can see complete cessation of bleeding with contracted and retracted uterus.
After application of negative pressure, you should not disturb the uterus, should no need to do even massage. If you leave negative pressure working inside for a minute or 1.5 minutes time, uterus slowly and become contracted and retracted. All the blood in the uterine muscle will go back into the circulation. It will be totally a bloodless field. You can see virtually how the uterus get contracted and retracted due to negative pressure when doing cesarean section. Prophylactic application of SR cannula is done for women who are at high risk for developing atonic PPH like PIH, anemia complicating pregnancy, and accidental hemorrhage, and so on.
For prophylactic application, we have to check the suction machine before the delivery itself for proper functioning. And we have to organize the cannula system. Cannula should be firmly fixed to the one end of the suction tube. Other end of the suction tube should be firmly fixed to the suction machine like this. After the delivery of the baby and before the delivery of the placenta, vagina retracted with white blood speculum. Mild traction on the umbilical cord. 5 centimeters of anterior cervix caught with the sponge holding forceps like this. After the delivery of the placenta, without wasting any time, left 2 fingers inserted deep into the cervix, cannula inserted into the uterine cavity, taking the guidance of left fingers, tip of the cannula at the level of fundus, negative pressure applied. You can see complete cessation of bleeding. Total blood loss is around 50 ml.
I would like to
uterus retracted well.
I would like to share one information here. Immediately after the placental delivery, we should insert the cannula. It is just within 10 to 15 seconds time we have to insert the cannula immediately after placental delivery. Otherwise, uterus, the cervix get constricted, closed, and it is difficult to insert cannula. But in case of frank atonic PH, there's no problem. Uterus, not only uterus, even cervix also atonic. Sometimes you can put your entire hand inside for a manual removal and all. So the most important for a prophylactic application, you should be very quick in inserting the cannula. Then only it will be easy. SR cannula for traumatic PPH. I suggest apply SR cannula for every case of PPH, whether it is traumatic or atonic. In case of advanced traumatic PPH, some amount of uterine atony is also possible. Cannula corrects this atonic component and reduces bleeding. When negative pressure applied, the cervical tissues get compressed firmly on cannula and stops blood flow in descending cervical vessels. If we apply gentle traction on the suction tube and cannula, the entire uterus en masse descends down into the vagina. You can apply speculum, visualize the tears better, and you can suture the better. As the blood supply from descending vessels come down, bleeding from the injuries will come down. And you need not apply the sponge holders to catch the cervix for exploration, because the suction tube itself will pull down the entire uterine mass and cervix. You can see the cervix and tears better and suture better. And this is the cannula. SR cannula for transporting the woman with the PPH. SR cannula is very effective for transporting the woman with PPH to higher medical centers. We apply this manual suction pump, which is available in every labor room. Previously it was there, now we are using suction machine. This machine can be used to create negative pressure inside the uterine cavity, very useful during transport and also in places where there is no power.
Manual suction pump can also be used to create negative pressure inside uterine cavity. This is useful in places where there is no power and also helps to transport the patient with in situ cannula.
How to remove cannula after the procedure? After the completion of the procedure, the cannula cannot be removed easily as the soft cervical tissues get sucked into the perforations of cervical portion of the cannula and become adherent. Cannula can be removed easily.
Cannula can be easily removed after gentle separation of these adhesions with finger manipulation like this.
This is the cesarean section done last night. Next morning, I'm removing the cannula. You can see clearly. We have to insert the index finger between cervix and the cannula and make a sweep around cannula, detaching the stuck tissues into the holes of the cannula. Once the tissues are detached, the cannula come out easily. How to clean the cannula?
To clean the cannula, immerse the cannula inside water. Kink the suction tube and put on suction machine and create high negative pressure inside the suction bottle. Then release the kink. By gush of entry of water inside the cannula get cleaned.
Whether SR cannula can produce inversion of uterus. SR cannula do not produce inversion of uterus, but inversion of uterus can be treated with SR cannula. We have to reposition the uterus back into the abdomen, and we have to insert the cannula into the uterine cavity, apply negative pressure. The atony in the uterus will disappear and uterus becomes firm and it will not recur. SR cannula is also very effective to stop uterine bleeding, even in case of coagulation failure. The case of coagulation is a case of abruption of placenta with coagulation failure. I have used SR cannula here. We could stop bleeding and we could also preserve her fertility function. And during the period of COVID infection, number of patients with coagulation defect could be saved by using SR cannula in different medical colleges. Further, if there is any difficulty, anybody can call me to this number. I have given my number here. I can come to their help. Under care of Government of Andhra Pradesh, SR cannula and oral hydration therapy to prevent severe preeclampsia and eclampsia were introduced in Chittoor district of Andhra Pradesh in July 2018. This is why I'm giving here is I'm just showing how rapidly the SR cannula system is spreading in the South India. Hands-on training workshop was conducted at District Hospital Chittoor. Suction cannulas were provided to all institutions conducting deliveries like PHC, CHC, area hospitals, and medical colleges. ANMs and DASHA workers were assigned the job of OHT to all antenatal mothers to prevent preeclampsia. Oral hydration therapy is nothing but making every antenatal mother to consume more than 3 liters of water after 24 weeks of gestation to prevent severe preeclampsia and eclampsia. This is my original work. This has been published. And in peripheral centers with suboptimal facilities, we advise the prophylactic application of SR cannula to all women, both in case of vaginal deliveries and cesarean sections. This is a 3 months review after the initiation of the program in Chittoor district. Within 3 months' time, 8,400 deliveries took place. 1,500 applications of SR cannula occurred, and around 429 applications during cesarean section and around 1,000 applications during vaginal delivery. You can see here, none of the maternal deaths occurred due to PPH, and you can see blood transfusion has come down. 28 blood transfusions only occurred for 8,000 and odd deliveries. 5 years performance of OHT and SR cannula to bring down maternal death MMR in Chittoor district. You can see here, we have introduced this SR cannula and OHT in 2017-18 August. Before that, around 47 deaths every year was there, 47, 46, so many deaths were there before SR cannula introduction. And now this year, the number of deaths have come down to 9 deaths. 47 deaths have come down to 9 deaths. The number of PPH deaths were 0 during the entire 1 year. For 30,000 deliveries, not a single maternal death occurred in the entire district. And you can see the MMR from 83, it has dropped down to 33.3. One important observation to observe you here, because of OHT, the maternal deaths due to PIH, 16 deaths were there 17-18, and it has come down to only 1 death last year for entire 1 year for 30,000 deliveries. So OHT is equally effective, very effective to bring down PIH deaths. The significant reduction in MMR is due to the combined effect of SR cannula and OHT. Now entire Tamil Nadu, Kerala, 80% of Andhra Pradesh and many major hospitals in Karnataka are using this SR cannula to prevent and treat PPH. Kerala Federation had introduced this device in its obstetric protocols to prevent and treat PPH. This is the MMR South India report I am showing here. In all 4 states, the 5 states, the MMR dropped very significantly. You can see the MMR in Kerala dropped to 19, which was never before. SRPPH suction cannula is a breakthrough innovation to prevent and treat atonic PPH. There's a paradigm shift in the management of PPH now. The panic adrenaline shift to the obstetrician had gone. And this is simple, cost-effective, life-saving and fertility-saving technique. It is a physical method, does not depend on biological factors for its action. For the same reason, it doesn't fail. No need to maintain cold chain. Suction cannula system can be organized within 2 minutes time. Bleeding stops just within 2 to 3 minutes time. Cannula system works well even in case of coagulation failure. Even staff nurses can be trained and the bleeding can be stopped without any delay. Highly cost-effective, autoclavable and reusable instrument. Helps to reduce maternal mortality due to atonic PPH in low resource settings. SR cannula should be made available at every delivery point in the country, and it should be used as a first defense, not as a last desperate resort after failure of all other methods. No child should become motherless in this country. We should achieve PPH death-free India and PPH death-free universe. Thank you. Thank you. Jai Hind.
So we would like comments of our chairpersons on such a wonderful video presentation.
Anybody can ask questions here. I'm ready to answer.
Punika ma'am is there. Ma'am will be giving her opinion. Yes, ma'am.
Sir, your presentation is really excellent. And I am using this cannula for few years now. And it's really very useful and helpful. So there is nothing to say anything else. It's really wonderful. And everyone should have it.
Thank you. Thank you. Nice of you.
Actually, thank you, Samartha. Am I audible?
Yes.
Yes, ma'am. Yes,
we were just at Faridabad, like it is a Haryana society. So it was an incidental. Dr. Jagdish from ESI hospital presented paper that suction cannula, how she has he have saved the life in very low resource setting. So this is the thing that we really wish to propagate, that the cannula's very simple measure is there in every PPH kit. This is the something which we are looking forward. And we wish to, Babita, you were worried. We have more than 300 attendants with us. So
I could not see anyone. I was so
so don't worry. All efforts are being taken care. And yeah, so we have 318 people with us as an audience. So so it is for it is a great to have. So Dr. Kunika, thank you for your comment, and you have used it. That is very, very heartening. That is very heartening.
Another important information I would like to offer is, if you have a cannula set with you and if you keep around 10, 4 or 5 people, and I can train from here. Usually what I do on a cell phone video call, will make on WhatsApp call, and I'll suggest them what to do. And we are able to do it very successfully. We tried 2 sessions and I need not come there. That's very nice to say. So
we will do it after elections, Amarta. Let me win the election.
That is why
Samar sir to our ISOPAP conference in November.
Yes.
That is why I want you to win. You, not for me, for the sake of mother, you should win.
Yes.
God should bless you that you should win. I wish that you should win.
Thank you.
So, ma'am, Sashi ma'am has gone for an emergency, so we'll conduct the panel before.
Yes. Anjuji with us, na? Hello, Shraddha. So good to see you.
If any questions are there, they can ask me. And
yes,
I can
any
answer.
questions?
Dr. Mitra Saxena, you were asking thinking of asking something.
Thank you so much. Actually, there was a question in the chat box. What is the price? So, sir, please answer that.
It costs only 11,200 rupees only for a set of 5 cannulas. It is so cheap, and they are reusable, made of surgical grade steel.
1100 नहीं 11,000.
Made of surgical grade steel. There are many people who are using in Haryana also this cannula.
Sir, I have used this cannula two times.
Oh, anyhow, thank you very much. So many friends are there in here only.
But I wanted to know, like I have written in the chat box also, how do you attach the tubing when you were introducing it in the uterine cavity and pulling it through the cervix? So the
Yes.
tubing was attached in like beforehand only, or like?
No, actually, I tell you one thing. You are asking for a cesarean section, right?
Yes, sir. Yes, sir.
So what I suggest, first you should know what is the dilatation. If the dilatation is 10 got 3-4 centimeter dilatation, you have to select the cannula. Larger diameter cannula, you should select if cervix is dilated. If cervix admitting only finger, not dilated, you have to select a thin cannula. There is a suction tube introducer and there is a cannula. One side you have to fix suction tube, one side you have to fix the cannula intended for application. Other side,
like one staff will introduce the tubing from down.
No, hear me first. Let me finish. One end of the suction tube, you have to fix the cannula which you are intended to use. Other end, you have to fix the suction tube introducer. So that suction tube introducer, you have to insert from above down into the vagina. One of the assistant will insert hand between the thighs, catch hold of the suction tube introducer, pull like that till the cannula come into the position. Then you have to adjust the position, and other fellow from down they connect to the suction machine, and once you keep the cut edges together, he will apply negative pressure, and you will close it cannula inside the uterus. You won't remove the cannula immediately after cesarean, and the cannula will be removed on the next day only after
Sir,
12 hours.
questions are there now. Like what? Like, can you show this one introducer how it is?
I have shown you in the video. I've shown video also.
And sir, another thing is, like, if it is a pinhole cervix, how we should
pinhole cervix and all, you have to dilate, otherwise it's not possible. From above, we have to insert a finger and dilate, and mostly that's very rare. Most of the times, I have seen humpty number of patients.
Not bleed, huh?
there because like
if it is so, tell me. If it is so bad cervix not admitting, you bring out the suction tube from through an abdominal wound, then you can. Okay. The best way, no such a case we encountered, and this cannula is being used since more than 5 years now. Lakhs of applications have taken place every day. At least minimum 1,000 applications will be there in entire South India. Such a bad pinhole cervix very rare. You have to make dilate the cervix so that we can introduce the cannula. That's why I made different sizes. Thin cannula is there. Thin cannula, it goes. It is around only 10 millimeters diameter. That works well.
Okay, sir. And sir, how to use this cannula for molar pregnancy?
Molar pregnancy, there's a different sizes are there. One with a larger diameter and a thin diameter in vaginal cannula. Longer cannulas are vaginal cannulas. Shorter cannulas for meant for cesarean section. In longer cannulas, one is with a larger diameter, another with a thin diameter. And usually you apply a laminator or mesoprostral, whatever it is. You have to dilate the cervix so that your cannula permits inside. Cannula can go inside. After the evacuation, you can, suppose if at all bleeds, in between also you can apply cannula and apply negative pressure. It stops. And you can take time, you can take some breathing time, you can organize blood, and then you can complete the procedure. Quickly you can complete the procedure, boldly you can complete the procedure. You insert the cannula, apply negative pressure. Even some products are there inside also, it works. But only
we can keep it, like, rather than like we get tired also while evacuating the molar pregnancy. So it is a good use.
Yes, so you can see one doctor from Bharati Karla from Haryana, I think she's, and what she said, no, placenta was not coming out, she started bleeding. what she did, no, she applied cannula, SR cannula. Then
Yes.
immediately bleeding stopped. After 8 hours, the cannula along with placenta had come out. So what I would like to say here, no, cannula works even with products inside, membranes, bit placental bits, even pieces of placenta, even partial separation of placenta and invasive placenta, some parts left. This even then it works.
Sir, have you used this cannula during secondary postpartum hemorrhage? Like when patients come after 10 days of delivery with retained products of conception, can we use this cannula for them
You
also?
can use it. Even you can use for AV malformation. We have treated AV malformation with this cannula.
Sir,
Actually, I did one cesarean. It's a cesarean, clear cut. I know nothing is there inside, and this woman came with bleeding after 20 days. Then what we did? No, she was so badly exsanguinated. I have to give 2 units of blood. Immediately she came. I immediately applied SR cannula, applied negative blood, bleeding stopped. We gave 2 units of blood, and she was resuscitated. Next day we have discharged. Another 15 days, again another bout of bleeding. Again we applied cannula, bleeding stopped. Again after 10 days, 15 days, again recurrent bleeding. Again we applied cannula. Actually, I was advising them to undergo AV malformation evaluation by CT angiogram, but they were very poor. And they were telling, sir, if at all bleeding is there, I'll come again. You apply cannula, I can become all right. They themselves were telling with me. And finally, after 4th application of SR cannula, there's no bleeding. She became all right. So I think I could answer your question well.
Thank you, sir. Thank you so much. Thank you.
Tell me, you can ask me anything.
Yes, sir.
So cannula is so effective. Everybody should have. My suggestion to you, you use cannula for every normal delivery, every cesarean. So blood loss for cesarean, blood loss for normal delivery is just 120 ml. Your postnatal recovery is excellent. And the next day itself, the woman get up and walk. And there is no thromboembolic episodes. The one important factor which make postnatal period miserable is the bleeding. If you can stop bleeding, your postnatal period is excellent. No infection.
Sir, if I may be allowed to say something, I think we should be very restrictive in our conveying the message, because we cannot start using it universally in every cesarean. I would not, would say that this is a appropriate practice unless it is backed with good scientific data, because AMTSL is the standard of care, and then you have the medical management. And I think that before we prevail a practice like this, that all cesarean it should be done or it should be started.
No,
I think that will not be I think, sir, I think that PPH has, I mean, everything that is there. You do not have one size fit all. You have AK-74, you have a tank, you have Bofor's gun. For PPH, you have everything. So according to the situation, a procedure can be utilized. So I would say that, yes, it's a good armamentarium in the, for an obstetrician. And yes, it should be in our labor room. And if, as over a period of time, if our professors in the medical colleges, they have volume of cases. हमारे पास तो एक आध केस होता है, हम उसमें एक में कर लेते हैं, that is not 100%. So we have to actually, before issuing a sentence like that, we have to, have very robust.
Hear me, I would like to offer my comment on this. We are suggesting the application of this cannula for every case in peripheral centers with suboptimal facilities, PHC, CHC area hospitals. Actually, entire Chittoor district, they are applying now. It is 5 years now. And not only that, all small nursing homes I'm recommending, because they don't have blood. They can't run for blood. The cost of it is very small, and only expenditure for one application of SR cannula is only one suction tube, which costs only 120 rupees. See, the question is, it is available. If you want to use it, use it. Otherwise, if you want to use it as a last resort, that is also left to you.
No, sir, you are very right. And if you already have a data of 5 years, very soon Foxy and all WHO and all can also introduce it. So I think that another thing
See,
is it's a foreign material. Please, I would like to say this, that SR cannula is a foreign thing which is going to be placed in the cavity of the uterus. So before we make it for everybody, so many things have to be evaluated. I think that was fantastic, and let's get on with the panel, Dr. Sadhna. Otherwise, we can keep on discussing SR cannula.
in
But I
Yes,
think
ma'am. Thank you so much. Let's continue with our panel now. So for this, I would like to thank you, speaker and chairpersons, for conducting this session so smoothly. And thank you, sir, for answering all the queries and answering so many questions. So I would like to introduce our moderator, Dr. Anju Agarwal, ma'am. Madam is presently Professor, Department of Obs and Gynae, Dean Academics, KGMU, Lucknow. She has more than 100 national and international publications. She has presented number of papers in national and international conferences, and she is winner of various awards. She has held very important positions. She's past chairperson of conferences like North Zone ISOPAR, Lucknow chapter ISOPAR, and she's vice president-elect North Zone ISOPAR. A very warm welcome to you, ma'am. Then we have with us Dr. Manjulata Verma. She's additional professor, KGMU Lucknow. She's been really humble to provide such a simple CV. Very warm welcome to our moderators. We have as expert panelist, Dr. Shraddha Agarwal. She's consultant Obs and Gynae, KC Hospital, New Sohana Road, Palwal. She is founder and past president, Jalwal Obs and Gynae Society, Palwal Obs and Gynae Society. She is member of Breast Committee Foxy 2019-21 and fellow of Indian College of Obs and Gynae, recipient of awards, and she has several publications to her credit. A very warm welcome to you, ma'am. As panelists, we have Dr. Ishika Nain from Hisar, Dr. Nancy Chakravarti from Hisar, Dr. Savita Singhal from Rohtak, Dr. Meenakshi Chauhan from Rohtak, and Dr. Sadhna Gupta from Palwal. I don't know why he's not displaying their CV. Dr. Ishika Nain is a laparoscopic surgeon and senior consultant at Sapra Hospital, Rohtak. Dr. Nancy Chakravarti, she is head of the Department of Obs and Gynae, Maharaja Agrasen Medical College, Hisar, and she's a practicing gynecologist. She has publications and trainings in various national and international publications, and she's a second winner at IMA Haryana State Open Singing Competition. So good extracurricular activity. We have Dr. Savita Singhal with us. She is senior professor and unit head, PGIMS Rohtak, Haryana, vice president Foxy Rohtak, convener of Haryana Obs and Gynae Society, more than 200 national and international publications. She's written chapter in books and 100 guest lectures. She's master trainer, good scientific wing, and her area of interest being adults and gynecology and high-risk pregnancy. We have Dr. Meenakshi Chauhan with us. She's senior professor and unit head at BD Sharma, PGIMS Rohtak. She has 34 years of experience. She's master trainer for emergency obstetric care. She's ex-secretary and vice president of Rohtak branch of Foxy, recipient Dawn's Award for Best Paper at ICOG and A. Gans Award for Best Paper at ICOG Guwahati. More than 100 publications to her credit. A very warm welcome to you. Then we have Dr. Sadhna Gupta. She is a consultant in Upkar Hospital, Palwal, Haryana, and she's got the Achievers Award 2018 for PMSME Haryana. So a very warm welcome to our moderators, our expert panelists, and our panelists. We look forward to a very interesting session. Over to the moderators.
So a very good evening to all of you. And we are really privileged to have such a stellar panelists. And I must at the outset congratulate Dr. Sadhna Gupta on conducting such useful PPH webinars. As we all know, PPH is a condition which kills a woman in the shortest time. as compared to obstructed labor, as compared to sepsis. A woman may die from PPH within 2 hours. So without much ado, we move on to the panel. Who's running the slides? Yeah, so a warm welcome. And we know every minute around the world, almost 380 women become pregnant, out of which 50% of the pregnancies are unplanned. And it is these unplanned pregnancies which are at most risk. And if a woman dies delivering these unwanted pregnancies, that's really tragic. Next slide, please. So almost 75,000 women die every year from PPH, and 99% of the PPH deaths occur in resource-limited settings like ours. And that is why we really need to discuss PPH. Every 8 minutes, one woman dies due to PPH. While the causes of maternal mortality are multifactorial, it is a leading cause. So what is PPH? We all know it is loss of more than 500 ml of blood during a vaginal delivery or more than 1 liter of blood during a cesarean. But our working definition is any bleeding from the afterbirth, which has the potential to deteriorate the condition of the mother. So without more ado, we move on to the first case. Mrs. A is a 33-year-old gravida 4, previous 3-term deliveries, admitted with 40 weeks pregnancy in active labor. Her expected fetal weight is 3.6 kg. Last hemoglobin 1 month back was 9.2 gram/cent. Blood group was AB positive. Next slide. So, Dr. Ishika, is she at high risk for PPH? And what can we do to prevent PPH? Dr. Ishika?
Dr. Ishika, are you there?
My journey in Foxy have been incredible.
Dr. Ishika?
Guidance of mentors, teachers, seniors.
Someone else can take it. If Ishika is not there, Dr. Nancy, you can take it.
Yes, ma'am. Good evening, ma'am. Hello.
Yes, continue.
Please continue.
Yes, ma'am. She is at high risk of postpartum hemorrhage. The risk factors being anemia, as in the case of Grand Multipara, delivering a macrosomic baby that is around 3.6 kgs. For prevention of PPH during active labor, we can have judicious use of oxytocin for the augmentation of the labor. During delivery, there should be active management with usage of 10 units of intramuscular oxytocin, then bimanual massage and controlled contraction. And after delivery in the 4th stage, we can look out for the uterine height, the tone of the uterus, and we can watch for bleeding every 15 minutes for 2 hours.
So thank you. Yes, that is very rightly mentioned. And as you said, AMTSL is the most important step. But another very important step is to identify anemia during the antenatal period and correct it so that the woman enters labor with a good hemoglobin and she is able to withstand the PPH better. Another very important intervention for natural contraction of uterus is immediately after delivery of baby, put the baby to the breast to initiate immediate breastfeeding, which releases oxytocin and promotes uterine contractions. So next slide, please. AMTSL we already know. So Dr. Nancy, your experience with use of carbetocin in prevention of PPH?
Yes, ma'am. It is a wonderful drug as a synthetic analog of oxytocin. As madam has already said, that it has got a much longer lasting effect. And the only issue is that it is a bit costlier. So working in a medical college, it becomes a little, the cost becomes a little issue. But otherwise, it has been a wonderful prophylactic drug for the control of PPH.
But the only issue is the cost. And that is why WHO recommends oxytocin as the best initial drug and carbetocin as a second level drug, depending upon the resources of the place where you are working. So now this woman delivered a baby boy weighing 3.7 kg following normal labor. AMTSL using oxytocin was performed. And when the placenta is delivered, which is complete, she starts to bleed with moderate flow. On examination, she is alert and conversant, and her vitals are pulse rate of 90, blood pressure of 120/74, respiration of 14 per minute, and temperature 37 degrees Celsius. Next slide, please. So, Dr. Savita, what will be your initial response? Dr. Savita, are you there?
Send it to the expert. Dr. Savita had joined, but she's having network issues to call me up. So
Okay.
she couldn't join. Yeah.
So maybe I expect definitely nothing better.
So, ma'am, first we'll call for help in this case, and we'll arrange for blood. Then I would like to put 2 tablets of misoprostol per rectally, and start RL for the patient. Take one more IV line and send all the coagulation blood for CBC coagulation profile cross matching. And uterotonic drugs like prostaglandin can be administered. Methergine if we have given before, and otherwise tranexamic acid also can be given immediately, because as ma'am said that tranexamic acid is more useful when it is given early than later. And meanwhile we check for we do a regular massage for the uterus and check for the contraction of the uterus, and when the blood is arranged, then we start the blood for the patient.
So thank you so much, and definitely these are the 4 important steps of the first bundle, that you call for help. Call for help is very important because a single person cannot manage this patient. And the 4 important points are uterine massage, IV fluids, uterotonics. Oxytocin is always the first recommended uterotonic, even if you have given oxytocin for AMTSL. So you start it at 20 units in 500 ml at about 40 to 60 drops per minute. And tranexamic acid, if she has been bleeding for less than 3 hours. So we have just conducted the delivery, so definitely 1 gram of tranexamic acid is to be given. Next slide, please. So Dr. Meenakshi, what IV fluids would you like to use and at what rate?
Hello, everyone. Whenever patient is in shock, we should give crystalloids. So crystalloids are the IV fluids of choice. In the meantime, while the blood and other products are being arranged, we should start crystalloids, and it should be a fast transfusion initially. So 500 ml of crystalloid solution we can just transfuse within 30 minutes. And later on, another 500 we can transfuse in another hour. So that should be
so very rightly mentioned. We give crystalloids, and we prefer to give not too much because ultimately they cause dilution. So we want to control the bleeding also. And our aim is to maintain the systolic blood pressure to more than 70 mm of Hg. So what uterotonics by what dose and route? Dr. Sadhna?
Commonly, oxytocin drip is the first choice, and with the uterine massage, and if there is still bleeding, then carboprost intramuscular is given.
So definitely oxytocin is the first choice, and the other options as initially mentioned, misoprostol, apometrin, carboprost, symptometrin, they are all available to be used as and when required. But the important thing is choose and give one medication at a time. Do not give a cocktail. So, what is the role of tranexamic acid in the management of PPH?
It is. What?
Ishika
Dr.
is again
Ishika
absent.
I don't think
She's
there.
absent, Ma'am. Dr. Shraddha has to answer.
So initially, actually, we were not giving tranexamic acid, but now there is evidence that tranexamic acid should be given. In fact, it is amongst the first line care bundle of PPH. So we have already shown.
So we give 1 gram as a 10% solution over 10 minutes. So after the first response bundle, the bleeding has decreased, but it has not stopped. On further examination, there were no tears, uterus has some clots, no products of conception, and still has a poor tone. It is relaxing intermittently. Pulse is 100 per minute, blood pressure is 100/68, and respiration is 16 per minute. Next slide, please. So now what next, Dr. Nancy? What is your second bundle?
Ma'am, we will see for the signs and the symptoms of PPH, and if the tone is there, then we can, and if there is no traumatic injury, we can always rule out for retained products of conception if they are there. And as a rule, the first thing is use of uterotonics followed by continuous bimanual massage and call for extra help. Do not panic in such a situation. And use of crystalloids. In the meanwhile, you need to send in the blood samples along with arrangement and cross matching of the blood.
So, ma'am, when these things are not working and we are seeing that the bleeding is still continuing, then at this point we can use this SR suction cannula, I feel.
Definitely. That is a good option if it is available. And otherwise, if it is not available, then we have the uterine balloon tamponade, which is available with all of us.
Yes. Catheter balloon can be used.
So whatever balloon you are using, condom catheter or a pre-made balloon, whatever is available at your place, that is the one to be used. So bleeding stops after the UBT placement, and vitals now are pulse has settled to 90 per minute, blood pressure is 106/70, respiration is also better, 14 per minute. Now, how will you monitor this patient in the postpartum period? Anyone can take it. I think Dr. Savita has not been able to join.
So now when we have, when the patient is stable and the SR suction cannula is still in, and we can just watch for again we can send the sample of the patient for hemoglobin, repeat hemoglobin. And meanwhile, we should keep our OT ready, and anesthetist should be called. Then we should also look for the amount of blood loss the patient had in this meantime. We can see that how much bucket is full, like we can measure the blood clots, and the coagulation profile of the patient is very important during this time, because if coagulation profile is little deranged, then we can arrange for FFP or the platelets. And the platelets, which because PRBC, FFP and platelets to be given in 1:1:1 ratio. And then again, when if we have started the oxytocin and the patient is catheterized, then we should look for the urine output also.
So very nicely summarized. And the important thing is that even after bleeding stops, we are not to leave the patient alone. We are to monitor her every 15 minutes for at least 2 hours, and thereafter every 30 minutes for another 4 hours, and thereafter hourly and then 4 hourly. So monitoring is very important, and the additional support in the form of blood replacement, or if we don't feel there's requirement of blood replacement, we can also give IV iron to build up the hemoglobin, and definitely monitor her output along with the other vitals. So in this case, we have seen that uterine atony is the commonest cause of PPH. Atonicity cannot always be predicted, though this was a high-risk case. Important thing is emergency preparedness, universal precautions, and functioning as a unit or team at times of emergency. And we must also conduct drills to train the whole team so that there's no confusion when there's an emergency. So timely decision and timely action is the key in saving lives in cases of PPH. So thank you very much. We move on to the second case, which Dr. Manju will be conducting.
Thank you so much, ma'am. So now, without wasting further time, am I audible? Hello, am I audible to everyone?
Yes, you are audible.
Yeah, okay. So we are proceeding to next case. Mrs. P.S. is a 32-year-old primary gravida with an uncomplicated pregnancy who just delivered a live-born baby girl at weight 3 kg. There was no risk factors for PPH. Placenta has not been delivered 10 minutes after the birth of child. So how long do you wait for the placenta to deliver before any manual intervention? Dr. Meenakshi, will you take it?
Yes. So normally we wait for around 20 to 30 minutes for the placenta, especially if she's not bleeding. That is important.
Yes.
If she's bleeding initially, then definitely we have to just see if we need to do something or give some drugs. And otherwise, if it is not expelled after 30 minutes also, then we need to see. Then we need to see if any intervention is required.
Yes, ma'am. So very truly said, but in 2009, WHO has also recommended that in the absence of hemorrhage, if no bleeding is there, women should be observed for further 30 minutes following the initial 30 minutes before you proceed for any manual removal of the placenta. So what interventions can be done for retained placenta before attempting manual removal of placenta? Dr. Sadhna.
What intervention can be done?
Yes.
Before attempting catheterization of the patient and manual massage and syntocinon in the drip and control cord traction.
Yes, very correct, ma'am. So there is also a latest recommendation, although the evidence is insufficient, that they have recommended, WHO has recommended intraumbilical vein injection of oxytocin for the helping the removal of the retained placenta. And one more important thing, that ergometrine is not recommended because it will cause tetanic uterine contractions, which will further delay the expulsion of the placenta. So there were no signs of placental separation and there is minimal bleeding. One of your staff member gives firm traction on the umbilical cord, and this results in brisk bleeding, and the woman collapses in next 5 minutes. Pulse is feeble, BP is 70/40 now. So what do you think is the problem? Dr. Ishika is not there. Anyone can take this?
Most probably.
It can be uterine inversion.
Yes, ma'am. So on examination, per-abdominally uterine fundus could not be felt, and on PV, polypoidal mass was filling the vagina, and definitely it was uterine inversion. So what next? And what are the do's and don'ts with inversion of uterus? Dr. Nancy, will you take it?
Yeah, you can always call for assistance for your health,
Yes.
and
Yes.
you have to discontinue the use of uterotonics. You have to maintain the airway, the breathing, and the circulation. Establish an IV access and begin with the fluid resuscitation. Cross-match the blood for transfusion. then you can always, wherever the patient is, suppose if the patient is in the labor room, then you can always do a sudden reposition of the uterus. The first part definitely being reposited in the end. And if the reposition is not possible, then you can shift the patient to the operation theater, where under GA you can reposit the uterus back. If still not, then you can use certain uterine relaxants like nitroglycerin or terbutaline can be used. And afterwards, when the uterus has been deposited back, then you can wait for the spontaneous placental separation.
Very correct, ma'am. So the most important thing for this is that as soon as the diagnosis is made, immediate manipulative measures will be of most help. So if os is closing down and uterus has begun to contract on the fundus, what measures will be taken to facilitate the reposition? Dr. Savita.
I think Dr. Savita is not there, and Dr.
Anyone
Meenakshi.
can take this?
Oh, yeah, the madam has already told that we can use some relaxant like terbutaline, so it will help in reposition.
Yes,
Easily it can be reposited, and of course there are other methods like inflation with saline and all, but subcutaneous terbutaline can be given, and it will help reposition. Quickly it can be reposited, and we should keep our hand inside. That is very important, and start this syntocinon.
So yes, very correct. So these relaxing agent, they do not only relax the uterus, but they will also relax the cervical constriction ring, and this will help for reposition of the uterus and treating the inversion of uterus. Very correct.
We should not forget about the analgesia.
Yes,
in labor room.
Yes, yes. So if the constriction ring is formed, which is not negotiable, what can be done next? Dr. Meenakshi, you can take this.
Yeah. These relaxants, usually the constriction ring relaxes. Otherwise, of course, these are the techniques which we use for chronic inversion. Like we have to do a laparotomy and do those Huntington technique. There we have to pull with Ellis or the other surgery where we have to cut the constriction ring.
Yes,
that can be done.
Yes. So if this is yes, ma'am. So if this Halton's and Huntington's technique both are there, so if constriction ring is formed, then we have to go for the laparotomy procedure, and Huntington's and Halton's have to be taken for the treatment purpose. So key messages for this case is that in absence of hemorrhage, we can wait for maximum 60 minutes before attempting manual removal of placenta. Do not give ergometrine and prostaglandins in case of retained placenta, as it will cause delay in the expersion. We have to strictly avoid traction on the cord, applying fundal pressure and forcible expression of the non-separated placenta. In case of acute inversion, earlier the reposition, higher the success rate. Do not try to separate the attached placenta in inversion because it will lead to massive hemorrhage. And in case of surgical recourse to inversion, we have to restore the anatomy first to prevent the urological injuries. So moving to case number 3, a 25-year-old second gravida undergoes induction of labor in view of post-dated pregnancy and delivers a healthy baby of 3.6 kgs. Episiotomy was given, active management of third stage was done, placenta delivered completely, and post-delivery her vitals were pulse rate 102 per minute, BP was 100 by 70 millimeters of mercury, respiratory rate was 14 per minute, uterus was well contracted, but there was continuous trickle of the blood from the vagina. So how do you identify PPH in your practice? Dr. Sadhna. Dr. Sadhna, are you there?
Yes, hello.
Yes.
That means
yes,
there is some trauma because uterus is contracted and there is trickle. So there may be injury to the cervix or in the vagina.
No, my question was like, how do you identify PPH in your practice? Like we are talking about visual estimation, or you preferably use this type of drapes, DASP drapes or collection bag for estimation of PPH?
Estimation. Yes. How many usually visual measurement is the quickest method.
Yes, that is the quickest method, and that gives you approximately, reliable type of measurement assessment if you are confident about that. So these type of measurement, we must be remembering that if the ppH is on bed only, approximately 1000 liter is lost. If there is spill of blood on the floor, that means patient has blood 2 liters of blood, and we must be having an idea if this kidney tray is full of blood, at least that is 500 ml. So visual estimation is the quickest method which we can use for the estimation of blood loss. So what are the clinical methods to recognize ppH in this patient?
Yeah, like clinical methods can be rule of 30 as you have shown. That's systolic BP falls by 30, heart rate increases by 30, urine output is less than 30 ml per hour, and hematocrit also drops by 30%. And also there is a rise in the breathing rate.
And this, yes, and this shock index is very important, which Dr. Sadhana ma'am has also mentioned in her presentation, that if shock index is less than 1, then this is normal. And if it is more than 1 shock index, that is indicating for severe ppH.
Yes.
So early resuscitative measures were done for this patient. So shock index was 1.02. Large bore cannula was inserted. On-call doctor was called. Fast crystalloid fluid was started. Uterine massage done. Continuous oxytocin drip was being given. 1 gram IV tranexamic acid was given. Bladder was evacuated. Placenta was re-examined for completeness. Uterus well contracted, but still trickling continued, and there were clots in the lower segment and vagina. So what could be the likely cause of bleeding in this case? Dr. Nancy, will you like to take it? Dr. Nancy, are you there? So anyone can take this. What could be the likely cause of bleeding in this?
Most probably there is trauma to the cervix or in the vagina, high in the vagina.
Yes.
Hello.
Yes.
Dr. Nancy is there.
Yes, Dr. Nancy, I'm repeating the question. What could be the likely cause of bleeding in this case?
Ma'am, there can be genital tract lacerations.
Yes.
Which can be in either form. They can be in the form of any tear that can be occurring in the cervix or in the vagina or any kind of perineal tears. Then, depending upon the grades of perineal tears, repairs can be done. As in the first and the second degree can be repaired as we repair the episiotomy tears, whereas the third and the fourth ones can be repaired in the OT by using 2
So here we are dealing with a case of traumatic ppH now. So there is one question for expert opinion, that exploration of in vagina routinely post delivery should be done or not. This is for expert opinion, ma'am.
We should always explore the cervix and vagina in our routine. But after, are you about the laceration in case
No,
of?
ma'am. If there is laceration or if there is suspicion of traumatic ppH, anyhow we are going to explore that. But there is question like, if there is no traumatic ppH, there is no bleeding, then exploration of cervix and vagina routinely has to be done or not. What does all panelists say, and what is the expert opinion? Anju ma'am, would you like to make comment?
I don't think that routinely we need to explore, because if she's stable and if there is no bleeding, one of the very important things to find that it is traumatic PPH is there is usually continuous trickle. In
Yes.
atonic, usually there's a bout of bleeding, but in
Yes.
traumatic,
Very
usually
correct.
there's a trickle.
Very correct, ma'am.
So we don't advise the routine.
Yes, I think most of the I
what
think
others say.
yeah. Let us hear from others also. Dr. Nancy, what do you say for this routine practice of exploration of cervix and vagina?
Depending upon how about the high the obstetric history of the patient is very important. If she's a grand multipara, you should, and if you think that there is a lot of bleeding, in those cases, definitely you need to do a PS examination to rule out if there is any kind of trauma, and also rule out for atonicity of the uterus. But otherwise, in routine cases, as in like in primi-gravidas with normal-sized babies and who are not having excessive amount of bleeding, I don't think it is.
So good that we have consensus on this point that if there is no high risk, patient is not having bleeding, so there is no indication of doing the routine post-delivery exploration of the cervix and vagina. So how should trauma to the genital tract has to be identified in this case, Dr. Savita? Or anyone can take this? Dr. Sadhna, will you take this? How to identify traumatic PPH or the point from where bleeding is there?
Yes, after catheterization, then the pulse speculum examination, and by sponge holder, the whole cervix is identified, and the type of bleeding, because from the uterus, if it is coming in gush, that means it is a mild PPH, which is
Usually, what we do is like take two speculums, same speculums, and ask the assistant to hold it from both the sides, and take four sponge holders and try to catch the lips of cervix and look for the cervical laceration, cervical tears, and also look for the cervical laceration if it is extending up or it is extending laterally towards the vagina, and identify the injury. Then I usually apply Botroclot also on the laceration site, and then I start suturing the tear.
So everything has been covered by expert, and we have to remember that good exposure and good light are the two key points which we need to keep in mind for when we are managing the traumatic PPH. And as ma'am mentioned, the systematic inspection and repair of all genital tract injury, what has to be done in these type of patients. So on pulse speculum examination, it was found that cervical tear at 10 o'clock position and extension of episiotomy was there, which was bleeding actively. So Dr. Meenakshi, what suture material and technique do you use for cervical tear repair? What suture preferably you use for cervical tear? And what important things which suturing the cervical tear repair? Dr. Meenakshi, you are there? Anyone can take this.
So first suture which I use is always 2-0 chromic catgut, not 1-0, because it is slight thin and needle is very small, so we can reach high up above the we go 1 centimeter or 2 centimeter above the tear, and we start suturing from above and approximate both the lips of the cervix. We always keep in mind that the cervical canal should not be sutured as a whole, and there should be a space between, so we can put a big dilator in the cervical canal, and then we can start suturing the tear.
So very correct, ma'am. Then patient, this same ways, the patient was shifted to OT, cervical tear was stitched, episiotomy was extending into the vaginal fornix. Cervical tear was managed, and now this episiotomy is extending into the vaginal fornix. For this, how will you manage this? What is the important point for the management of this?
So again, we have to identify the apex of the tear, and we have to we start suturing from there. And while taking the sutures in vagina, we always keep the what do you call this round thing, round gauge we make for this, and we just pack the vagina behind with that, and then we start suturing the vagina so that the trickle doesn't come from up, and we are able to suture it nicely.
Yes, ma'am. And when the this episiotomy is very deep and apex is too high, these stay sutures really help. And with the help of these stay sutures, giving traction, we can really go above the apex for a better suturing. So by this time, patient has lost considerable amount of blood and is looking pale. The tear was staged, slight oozing still present, tight vaginal packing was done. Her pulse rate is now at present 125 per minute. BP is 96 by 60 millimeters of mercury. Her hemoglobin is 5.9 gram percent, and then platelet count is 1 lakh, and her INR is 1.75. So what are the important features of post-operative care in this patient?
So pulse is still high for the patient and the hemoglobin.
Anyone can take this, or only our expert is answering each and every question?
Ma'am,
Yeah, Dr. Nancy, you want to answer this?
yeah, since the hemoglobin, there is a fall in the hemoglobin, you need to transfuse packed RBCs.
Yes, definitely, yes.
And you need to give fresh frozen plasma, and platelet is 1 lakh. So it depends upon the upon the bleeding. If if like with the help of blood and FFPs, if it is controllable, well and good. And the post-operative care, you need to give laxatives for at least 3 to 4 days to these patients, and antibiotic cover. And rest in the future, I mean, these patients can deliver vaginally, but cesarean section is advisable.
Yes. So everything has been covered, but
chances to the anal sphincter in the future will be.
So now we can order for blood components because her INR is 1.75.
Yes, yes, ma'am. 1.75, we have to give her FFP, and hemoglobin is 5.9, so blood has to be transfused. And the most important thing, that monitoring of the vitals has to be kept on. So what are the protocols for transfusion of blood components, and should coagulation parameters define blood component replacement in these type of massive PPH?
Absolutely.
Anyone, Dr. Shraddha, you can take this as an expert.
Yes. So blood transfusion, as we know, like when we give PRBC and FFPs, because INR is high, so we have to give all the components like PRBCs, FFPs, and platelets. So these have to be given in the ratio of 1:1:1. And while giving the this one blood components, we have to monitor INR again, and we have to order we have to look for the DIC again, and when we have packed the patient, we have to monitor her that while the pack is soaked or not again, and look for the urine out.
Yes.
So for massive PPH or massive transfusion protocol, this 1:1:1 ratio is gold standard, and which needs to be followed. So what is the role of factor 7A concentrate no 7 in this coagulopathy? Anyone can take this?
So like when the patients are suppose some patient is having factor 8 deficiency or coagulopathies, or the person is thalassemia minor, in those patients I think we can give.
Yes, ma'am. So this Novo 7 is basically being used at present right now in these hemophilias and other coagulopathies, and because this is extremely expensive and there is no routine use is still not recommended in the management of major PPH unless it is a part of a clinical trial. So we are not routinely using it, but in coagulopathies this is having a good result but a bit expensive. So her story continues in this patient till now. 2 units blood transfusion given because her hemoglobin was 5.9, 1 unit platelet given, and 1 unit of FFP was given. Vitals are pulse rate 134 per minute, BP still 90 by 56. Now patient is becoming drowsy, and on examination, now uterus is pushed to one side. What could be the problem? We have explored vaginally, we have stitched cervical tear, we have taken care of this episiotomy, deep episiotomy, but still patient is having not regained her vitals and she's becoming drowsy. So what could be the problem in this patient?
Intraperitoneal, not exactly intraperitoneal, supralevator.
Yes, yes. Yes, ma'am. So Because
we have to prepare the patient for laparotomy.
Yes, ma'am. So uterus stage pushed being a side is the catch point for the diagnosis of supralevator hematoma, and they need to be treated by laparotomy only. So that is all for this case. In case, the key messages for this case is that in case of traumatic PPH, we have to resuscitate and stabilize the patient. We have to do the systematic evaluation of genital tract from above downwards. Systematic evaluation is of utmost importance. Visualization and securing the apex of the tear is important to control the bleeding. Repair has to be done from top to bottom, cervix, then high vaginal tears, then episiotomy and other extensions. And if patient is not improving, then we have to definitely rule out uterine injury. So these are 3 cases for panel. So I would like to thank our knowledgeable panelist and the most active expert, Dr. Shraddha, ma'am. And thank you so much for making us part of this panel discussion.
Okay, so kindly stop screen sharing.
Yeah, ma'am.
So thank you to our moderators for such lovely selection of cases, and to our panelists, and of course our expert panelist. She was of great help today because 2 of our panelists couldn't join because of network collections.
Yeah,
we got some really very interesting inputs. PPH is something like how much ever we study, it is like still there is something is lacking. So now, thank you to our moderators, Dr. Anju and Dr. Anju Agarwal and Dr. Manju Lata, and to all our panelists and expert panel, Dr. Shraddha Agarwal. Now, quickly moving towards our next session. It is a video demonstration of stepwise devascularization and internal iliac artery ligation. Unfortunately, Sashi Kabra ma'am is in an emergency. We will try to play the video and explain. My Sadhana madam is there and we'll try to explain. For this, I would like to invite our esteemed chairpersons, Dr. Jatinder Chadha. She is president of Yamuna Nagar Obs and Gynae Society, and Dr. Mithilesh Bansal from Palwal. Kindly display the CV. So Dr. Mithilesh, she is a senior consultant, gynecologist and sonologist, director of Bansal Hospital, Palwal. She is past president IMA 2019, first lady president, best president award of decade. She is past president Foxy Palwal 2015 to 18, and she's been awarded DC and the Huda administration in health services, awarded by Sri Anil Vij in PMSMA. So she's an active member of IMA, Palwal Menopausal Society, and Foxy for more than 30 years. A very warm welcome to Dr. Mithilesh and Dr. Jatinder. A short introduction of Shashi ma'am, and then I'll try to share a video. So, Dr. Mithilesh, are you there?
Yeah.
Okay. Kindly display CV of Dr. Shashi ma'am.
Dr. Shashi Kabra, IMA Appreciation Award 2018, recipient of Wonder Foxy Award 2019, APJ Abdul Kalam Appreciation Award 2020, IMA Women Doctor Wing, Karamveer Award 2021, Champions Award of Gynae 2021, APJ Abdul Kalam Excellence Award 2022, Asia PCC Award Quality Leader Healthcare 2021, Rashtriya Gaurav Award 2021, National Mental Lux in association with all WHO member Practical Obstetric Committee Foxy, Medical Education Committee Foxy. So there are so many awards. We will talk stepwise devascularization in PPH.
Okay. So
Dr. Shashi Kabra, welcome to you.
Shashi is not there. Unfortunately, she is really stuck in emergency and she was in ICU. So I will, Babita, you put.
Yes, I'm trying to share a video, ma'am.
Yeah, Dr. Babita will show.
डॉक्टर बंसल आपने ना शायद 2 से ज्वाइन कर रखा है तो इको थोड़ा सा आ रहा है बट इट्स ओके बट इट्स ओके It's fine. So actually,
Ma'am, I'm not getting share screen option. I don't know why.
मैं देखती हूँ this one is there.
आपको मेल करूं? मैम का टेलीग्राम पे भेजी है, आपको मेल करूं?
ये देखो मैंने शेयर किया, it is visible.
I don't know, it's not showing share screen for me.
दिख रहा है आपको?
मैं देखती हूँ, फोन से ट्राई करती हूँ.
Babita ma'am, you can rejoin actually. Then you will get a share screen. Yeah.
Okay.
Please exit and rejoin.
आप करें. मेल करके देखो.
No. Yes, वो तो क्या? ये कौन शेयर किया? हो गया है.
Good afternoon. So now I am showing you the billings uterine compression sutures on the model of the uterus. This is an educational model of the uterus, and I give sincere thanks to Dr. Sheila Mane, who has given me this educational model for teaching purpose. And it was made by Sir Christopher Bill. This is the anterior side of the uterus, showing the LSCS incision, upper flap, lower flap. This is the cervix, and this is the posterior side. Now, before applying billing sutures, we have to confirm whether the suture will work or not. So, we have to exteriorize the uterus, put one hand on the posterior side, and have to compress with this, and we have to see if the bleeding is reduced. If bleeding is reduced after applying this pressure, then we can presume that this suture will work, and we can proceed with these sutures. Now, what suture material are to be used, I have told you in details in my presentation. Here I am using catgut number 2, 90 cm length, 70 mm thickness, blunt round body needle. So let's proceed with the sutures. So we have to identify few points. On the anterior side, this is the LSA scar. There is point A, 3 cm below the lower incision and 3 to 4 cm medial to the lateral side. Then we have point B, 3 cm above the upper part of the incision and 3 to 4 cm medial to the lateral side. And similarly, we have point E and F on the opposite side. And we move the uterus posteriorly. Then we have point C, which is just behind the location of point E and point A and B. And we have point D, which is just behind the location of point E and F. And they represent the site of insertion of the uterosacral ligament. Now proceeding with the sutures. This is point A, 3 cm below the lower flap. I am going from outside to inside at the lower flap and enter the uterine cavity. Then from inside to outside I am coming out through point B, which is 3 cm above the upper uterine flap. Now my assistant will help me and I will curl around the fundus. This distance is 4 cm medial to the uterine column. Hold it like this. This is point C. Now I will pierce from point C and will come out anteriorly in the uterine cavity. Now I am inside the uterine cavity. Again I will pierce through point D and will come outside. So this is the location of point D. And I have come out outside posteriorly. Assistant will again help and he will keep on compressing the uterus. Now I will enter the uterine cavity again through point E. And will come out again through point F. Assistant will throughout keep the uterus compressed, and now we hold it. Then the uterine incision suture is to be closed, and we have to take utmost care of the angles. And now I will tie the sutures. Keep it compressed. First turn, second turn. This is squaring of the knot. Next to this. Right. This is second suture, and this is third suture. So it will look like this, and we can cut it. So this is how the billing suture will look anteriorly, and this is how the billing suture will look posteriorly.
Actually, this is the compression suture. We will like to have the comment from chairperson as well, just to say that first you have to see that when you compress the uterus, the bleeding stops or not. If bleeding stops, only then you go to the baleen suture. And we can have a lot of compression suture. We will, I think, go straight away to internal iliac ligation. So, no, not this one, not this one. I mean, like just because we will go to straight internal, this one. So we will have discussion from the chairperson that it is important that you select the patient well, because if it is not working, then sometime when you have a localized bleeding, you can have a cross suture at that very point. And the Heyman suture, which is very, very easy. Actually, in reality, we are using the Heyman suture, that is a modified lint. So you give this suture right from below and anchor at the shoulder of the uterus, that is corner of the uterus, and that is very, very easy. So we have less time, and we do it in a less time. It needs less expertise and minimal entry also, and you can do it even when there is a no cesarean scar over that. So we will going to play the internal iliac ligation, the video, because that is the, yes. Voice. Able to hear voice. Voice नहीं लगती मुझे तो नहीं आ रही.
वॉइस नहीं मैडम हम पढ़ दें.
हाँ.
अच्छा.
Hello everyone.
Yes.
So today we will discuss internal iliac artery ligation. First, I will show you how to make a double thread. So see in the picture, I am using number 1 silk and have doubled the thread. Now I am showing you how to do internal iliac artery ligation. In this case, we had already performed the obstetric hysterectomy, and now we are proceeding towards performing internal iliac artery ligation. You see here I am recognizing the structure, the ovary and the infundibulopelvic ligament. And for opening the retroperitoneum, first we will locate the cut end of the round ligament. You see, I have located the cut end of the round ligament. And from the cut end of the round ligament, I'll go parallel and by the side of the infundibulopelvic ligament up to the lateral pelvic wall, and slowly lifting the peritoneum and taking care not to cause any injury on other structure. And I am moving towards lateral pelvic wall, and my incision is just parallel to the infundibulopelvic ligament, and I am opening the retroperitoneum around 5 centimeter, and the retroperitoneum is open now. I am extending it, not injuring any other structure, and this is how it has been opened. And now I'll kept away all the instruments, and with my 2 fingers I'm opening and enlarging the loose areolar tissue. I'm enlarging the incision site. It is a loose areolar tissue, so does not bleed much, and this is how retroperitoneum is opened. Now I will try to locate the important vascular structures. I can see the ureter in the medial flap. This is the ureter in the medial flap, and we will work on the lateral side. So ureter doesn't come in way once we retract it medially. Now the first and foremost thing for performing internal iliac artery ligation is to recognize the inverted Y. The common iliac artery divides into external and internal iliac artery. You see here, and it takes the shape of inverted Y. This is the internal iliac artery ligation of right side. And you can see here, the external iliac artery is visible. When I press the external iliac artery and simultaneously when I press the femoral pulse, then femoral pulse goes, and when I lift the pressure on external iliac artery, then the femoral pulse comes. Femoral artery is a direct continuation of the external iliac artery, and this is how we recognize and exclude the external iliac artery, and we concentrate on the internal iliac artery. When we press the internal iliac artery, there is no change in the pulsation of the femoral artery. You see here the external iliac artery is behind my fingers, and the site of our ligature will be around 3 cm below the bifurcation, and we will remove the sheath on the artery only at that area where we are supposed to apply the ligature. Now this is a right angle forceps whose end is blunt, and now you see how I am separating the sheath around the internal iliac artery. Just see, look at the movement. It is parallel to the artery. It can never be perpendicular to the artery, because if we do the dissection perpendicularly, then we will end up injuring the other important vascular structures like external iliac vein or internal iliac vein. So this should always be parallel to the artery. You just see, look at the dissection. Very gently I am doing the dissection with the right angle forceps. Its end is blunt, and it is also called mixture forceps. You just see how I am separating the sheath. Yes, and the proposed site of my ligation is around 3 cm below the bifurcation of the common iliac artery. The bifurcation is represented by the inverted V, inverted Y. Now the sheath is being separated. Now doing little bit of more dissection, and I will pass the right angle forceps from lateral to medial. So just see, from lateral to medial I will pass it. So I am passing it and grazing through the artery so that not to injure any other structure below. So the right angle forceps has been passed from lateral to medial below the internal iliac artery. Now my assistant is giving me the double thread. I pulled it up. Yes, and now I will cut it at the end which was double. Yes, here I am cutting it, and now the 2 threads are made, and now I will try to separate the threads as they are entangled. So I will separate the threads, and I am gently, very gently, with utmost care, I am separating the 2 silk threads. Now they have been nicely separated. Now one by one I will ligate them. You see beautifully they have been nicely separated. Now I will ligate the lower one first. My first knot is always a surgical knot, double turns, and look carefully. My fingers are going below in the depth of the abdomen. I am not pulling the artery at all, because that will make a catastrophe. So I place the knot just on the top of the artery, very gently, not pulling the artery at all. And now my first knot is completed. I'm giving the second knot. And now the third knot. Every time I'm taking care not to pull the artery, rather taking my hands up to the artery. Now I'll cut this. So the first ligature given. Now I'm getting hold of the second ligature suture, and this should be 0.5 mm away from the first one. So again I'm giving a surgical knot, placing it on the top of the artery, and of course 0.5 centimeter away from the previous one. See, there is a distance of 0.5 centimeter between the two ligatures. I've tightened the suture, not pulling the artery at all. Now I'm applying the second suture. And now the third knot. Second knot and third knot. And very gently, without pulling the artery, I'll cut the thread. So both the ligatures have been applied. Now you see. So you see now this is the inverted Y. And we can see that this is common iliac, this is external iliac, and this is internal iliac anterior division with ligatures.
So this is the key points are wonderful. I think, yes. So it's done. Stop share. Thank you. So we will like to have a comment of chairperson so that after that we can have a discussion about it. We are really regretting the presence of Dr. Shashi Kabra is her personal presence. So Shraddha, your comment, any Dr. Bansal, you are with us. So please.
If any time this artery is injured and there is massive bleeding, then what can we do?
Then you have to do, actually this is the thing, that's why we are keeping this, that actually, and this is actually not a very remote possibility. So internal iliac artery ligation is something when we have to consider, like when we have a pelvic, like we are not having any bleeding site, any bleeder, broad ligament hematoma is the thing. When we have a very ragged uterine rupture, when there is a bleeding all over from the pelvic vasculature, then we have to resort to internal iliac artery ligation. And that's why this is the video. That's why we have to have the right technique so that we don't injure. So what Dr. Like this video displays very, very strongly. Secondly, the right space to open up. That is the round ligament infundibulopelvic, then follow 2B where common iliac is being divided, and then where it is the following, right, inverted Y, and you go 5 millimeter actually below that, so that you are at the right place. What you say, how actually we will say how we can avert the vascular energy, injury, and that is never go dissection perpendicular. First thing, that is very important. Then always it is L to L. This is lateral to medial. So this is very important. If you like have any revert like medial to lateral, then you will injure the vein, and that is very important. And don't pull the artery. This is very, very important. Don't pull the artery above. You go thread to the artery. So you take your thread, you have to respect the artery, you have to go there to that, and then you, so that is the thing. God forbid, if it is not only the arterial injury, even if we have the venous injury, that also cause a lot of, can be the bleeding. And that is the need that we must have the backup of vascular surgeon, and with a very fine suture material. Yet this is the complication, and another complication which we have, the inadvertent ligation of the external iliac artery. So sometimes we have this sharing of cases that the patient have this vascular supply and the like vascular issue, neurological issue because of the inadvertent, and that's why internal iliac artery is like, no, it is the thing which not everybody is doing, and why we are keeping this video, that you learn in a clean case, like in a gynecological surgery, in a clean obstetrical surgery case. And once you are having this 2 or 3 or 5 or 6 exposure, that how you do, then you can do it into the emergency. So always there is always a fear, because as a obstetrician, we are not in a routine practice to go retroperitoneally. So retroperitoneal dissection is something which we have something fear out of mind. But this is the internal iliac artery ligation, because we have wonderful oxytocin drug, a very good response of the simple devascularization measure, that is a uterine artery ligation, uterovarian ligation, double ligation, compression suture, and SR cannula also. Very, very good thing. And internal iliac artery ligation is not, it is actually now very less needed than before. And the placenta perpetua spectrum is the another thing where this is said. But what is the real experience, that it is not the vessel, like actually it does not help much. And then the tourniquet actually help us, because we have the bleeding from every side, so many collaterals, that sometimes internal iliac artery ligation does not help. So very, very select situation, now much lesser than before actually. But this is the thing that which we have to learn, which we have to rehearse, and we have to like avoid the complication. And sometimes, of course, it is not the vascular energy, but the neurological injury or something. Sometimes we have saved life and the mother is there, then when we can do further. So I hope we really regret that the availability of Dr. Shashi Kabra, who is very passionate about this subject, but we have to know, and I think video was very clear, and lateral to medial parallel dissection and going thread through the artery and not pushing the artery, that is the thing which actually finally makes them. So
very good video, very well explained. Thank you so much, Dr. Shashi. I have seen first time section.
Yes. So we will be inviting you for chairing other session. Babit, thank you very much. So Shraddha, your comment about it.
Yes, ma'am. Definitely, when in case we are going for obstetric hysterectomy, in those cases, internal iliac artery ligation is very useful, I feel. And one more thing I would like to know is like whether in your practice, ma'am, have you applied that red rubber catheter at the level of internal os? And
Anything very good. It is very good. It is a red rubber catheter or a simple K90 catheter, because
even
then you don't have
catheter, we can tie it.
sterilize something. It is very good. Actually, internal iliac ligation is something which is like we talk too much, because it is a difficult thing. A little expertise is needed. But actually, for the PPH management now, it has got a very less, but it's more important in gynecological oncology surgery and the other like a few things. But PPH is something, yes, sometimes it can be life-saving, and more so the uterus saving. What we can say, uterus saving.
Because by the time you apply it and by the time you suture it, uterus gets contracted.
Uterus saving.
Even in broad ligament hematoma, when we are unable to localize the bleeder, so that is a life-saving procedure.
And sometimes, ma'am, we are not able to locate the uterine artery also. That time also we can just tie it and then just keep it for some time like that.
So it is the thing, compression sutures, Heyman suture, co-suture, very, very simple. And the uterine artery ligation actually works quite well. You do like this at the level of the lower uterine segment, take a window, take the muscular bite and go from the broad ligament window and tie it, and the uterine artery ligation really works very, very well in many situations.
Sometime back, like Dr. Mitra ma'am had told me that once an obstetrician, always an obstetrician. And today I could recall everything after a long time. Because I'm not doing like so many obstetric procedures nowadays. So
he's into fetal medicine, she told me. I said, don't worry.
I was really surprised that I could recall like so many things what I was doing before. So thank you so much, ma'am. It was really like you have, like I have relived that that obstetrician practice now, today.
Dr. Sadhana, we wish for Bhakti President.
Yes. आप सबको
Yeah.
वोट देना है और अपने
And you are
सभी
from
दोस्तों
Gorakhpur. Dr.
Yes,
Sadhana, you
yes.
are from Gorakhpur. And very much soft corner for you.
You must have a very, very soft corner for me. For many reasons, I am evolved out of you, your city, your reason.
Really,
And very
you
much.
deserve this. You deserve this post. From last 10 years, I'm waiting for you to become president.
Kindly,
Dr. Usha Sthana
all
post
your
me.
friends also and all your
Vote for
please
Bhakti
vote for
President.
madam.
Dr.
Kindly
Sadhana.
spread the message in your society. It is very important. Every vote counts. Every vote matters, isn't it?
Yes, really.
You say Sadhana Gupta from Palwal, Sadhana Gupta from Gorakhpur. And both are very sweet. Both are very sweet. I am also right.
Thank you, sir. Yes. साधना का मतलब ही साधना होता है ना
साधना का मतलब तो मैडम आप कौन से बैच के हैं
मैं 76 बैच की एंट्री है मैं लेकिन गोरखपुर की मैंने मेरा एजुकेशन आगरा में है सेंट मेडिकल कॉलेज
अच्छा गोरखपुर से नहीं गोरखपुर में प्रैक्टिस कर रहे हैं आप
मेरे को तभी आफ्टर पीजी इट इज अ लॉन्ग जर्नी 30 इयर्स वी हैव फाउंडेड फाउंडर मेंबर ऑफ गोरखपुर. So Babita, we can conclude. We can give
today Aishi will give the official vote of thanks, ma'am. We have called Aishi today.
Thank you so much, Babita. So sweet, Dr. Babita. You are so sweet.
Thank you, ma'am.
Aishi gave a vote of thanks so that I will be just a webinar with the Southern Society.
Best of luck, ma'am. Best of luck. Yeah, best of luck.
Thank you. Aishi, go for the.
So at the outset, I would like to express my gratitude to the societies of Gurgaon, Ambala, Hisar, Rohtak, Yamuna Nagar for coming together for today's program. I would like to thank our chief guest, Dr. Ragini Agrawal ma'am, for gracing today's webinar and giving her blessings. My sincere gratitude to our guest of honor, Dr. Mitra Saxena ma'am, for the words of wisdom and motivation. I would like to thank the presidents and secretaries of the societies, Dr. Pushpa Daya ma'am, Dr. Ritu Jain ma'am, Dr. Kalika Chechi ma'am, Dr. Meenakshi Mehta ma'am, Dr. Jalinder Chada ma'am, and Dr. Mithilesh Bansal ma'am for chairing the session and giving their valuable inputs. Regards and congratulations to our wonderful speakers, Dr. Sadhana Gupta ma'am, the key organizer of this series of wonderful webinars for the excellent job. Dr. Samartha Ram sir for sharing with us his innovative idea of SR cannula that will benefit us all. Dr. Shashi Kabra Maheshwari ma'am for sharing the very informative video on stepwise devascularization. I would like to extend my gratitude to the moderators, Dr. Anju Agrawal ma'am and Dr. Manjulata Verma ma'am for planning such wonderful case situations for the panel discussion. I extend my thank you to Dr. Shraddha Agrawal ma'am for sharing her expert opinion and giving us the useful tips. Next, I would like to thank our esteemed panelists, Dr. Ishika Nan ma'am, Dr. Nancy Chakravarti ma'am, Dr. Savita Singhal ma'am, Dr. Meenakshi B. Chauhan ma'am, and Dr. Sadhana Gupta ma'am for giving the valuable insights and engaging discussion. I would like to thank Dr. Babita Shukla ma'am for all the hard work for making this program successful and the IT team for the excellent platform. Thank you, audience, for being here. Thank you.
So thank you.
So, So done. Thank you very much, Babita, Aishi, for all vote of thanks, all wishes. And I wish, earnest appeal that you, everyone, become your ambassador. This is the time to change. This is time to have the hosts who have done work. And for all the things which we wish to change, for the simplicity, for the ground root level work, for working for our fellow Bigini, as well as working for our all women health pan India. So thank you very much for being with us, and it is a beginning of great journey, and we will be always together. Thank you, Corona. Thank you, Piyush, for being with us. So we can.
Thank you so much, ma'am.
Bye, Shraddha. Bye. So.